Welcome to this video presentation of our series, Racism and Race, the Use of Race in Medicine and Implications for Health Equity. This is a recording of the first session in this series that took place on March 24th, 2021. Our session brought together scholars and experts who differ in their perspectives on how race has been understood and should be addressed in medicine, and how we might do this in a way that achieves the best for our patients and the communities we serve. After 3 plenary presentations, the scholars had the opportunity to respond to each other's presentations. Discussion, debate, and disagreement are part of the scientific method, and we are appreciative for the willingness of these experts to engage in that work to advance our understanding of this important and complex topic. Good morning, and welcome to our series of discussions on the use of race in medicine, implications for health equity. I'm Kirsten Bibbins-Domingo. I'm professor and chair of the Department of Epidemiology and Biostatistics at UCSF. I'm also professor of medicine and the inaugural vice dean for population health and health equity in the UCSF School of Medicine. The UCSF School of Medicine Dean's Office has been pleased to host forums on topics that are timely and relevant to population health and health equity. And no topic is more timely or relevant than this one, both for population health and health equity, but also for the practice and the teaching that we do in our medical schools. And that is why we are really pleased today to co-host this event with our fellow medical center campuses of the University of California. I begin with this photo of our students. They are both the inspiration for much of the discussion that we will have today, as well as they have pushed us to really have these types of discussions. They are often on our medical school campuses, the conscience of our campuses, and force us to think about how we can live up to the ideals to which we aspire. This photo also reminds me of the ways in which medicine and society are intertwined. Medicine reflecting the larger societal discourse that we're having at this time, our urgency to dismantle structural racism and systemic oppression, but medicine also in its practice and teaching contributing to these larger societal structures that we are talking about today. And I think we will touch on all of that in the course of these discussions. We are today, and through this series, exploring a very specific slice of that larger conversation of racism and race in medicine, how we use racial categories in what we teach, in how we practice, and how we conduct research. This is just one slice that we will have and a set of discussions that we will have over a number of Wednesday mornings. Our goal here with today's discussion is to lay the foundation, to understand the historical context of the use of race in medicine, as well as current perspectives. To use this understanding, then, we will look at a series of case studies over the subsequent weeks to really explore this more deeply in its application to the work that we do on our campuses. And then later in April, we will delve even deeper into our 3 mission areas and how what we have understood from the earlier sessions really inform how we should be teaching, practicing, and conducting research with our understanding of this context from the prior sessions. It's in our last session that we will finally have the opportunity to have breakout groups and really get down to the specifics of the implications of this for our own work. The principles that guide us throughout are 2. The first is that we aspire to be an anti-racist institution, and the second, that we are driven by health equity. The pursuit of health equity for our patients, for our communities, and for the populations that we serve. These are the principles that have really guided us in planning this series. These are principles that I am sure all of the speakers and organizers would espouse. It is in its application of these principles to the specific work that we do that there is complexity, that there is nuance, and there will be controversy as you will listen to the speakers who talk today. I think it's important for us as academic medical centers to really embrace and tackle the nuance and complexity of these issues for our work. Zoom, I want to acknowledge, is a wonderful platform that is allowing us to have this discussion with the more than 1,000 of you that are registered for this session today. It is not always the platform that allows for the most nuanced of discussions. And so acknowledge that there will be times and spaces that we will have to extend what we present here into other types of venues to really bring out the nuance. And we hope that you'll continue to engage with us as we explore that as well. So today we'll start with keynote sessions. We'll then have a break and come back with a moderated discussion with our keynote speakers, followed by a second moderated discussion with a responder panel with colleagues from across the UCs. We'll end with Q&A and closing comments. I'm really thankful for having had a fabulous steering committee with colleagues from across our UC campuses. These steering committee meetings were really extraordinary and really had an enormous impact on how we structured these conversations. And I learned so much at each of the meetings. I'm grateful to Dr. Christine Dellendorf, Professor of Family and Community Medicine at UCSF, who is my co-organizer of this event, and to Stephanie Belger, who's the Associate Dean for Strategic Initiatives in the UCSF School of Medicine, who almost effortlessly got us to the point that we could have this really complex set of discussions. So some housekeeping. We will do questions after each talk. You can submit the questions in the Q&A link. Obviously, with such a large audience, we will not get to all of the questions, but I will assure you that the questions that were submitted when you registered did help us in crafting questions for the speakers, and these questions we will keep that remain unanswered for our upcoming sessions. We have a website that you can access through the QRS code. We will post a recording of today's discussion. There will be information of the upcoming sessions. We have fabulous speakers whose bios are really extraordinary, and you should read more about them on this website, as well as look at the library of resources that they have recommended for you to explore this work further. So with that, we will launch our keynotes. And I will say I am thrilled that we have three really outstanding speakers and scholars to start us off on this set of discussions. First, we will hear from Professor Dorothy Roberts. She is the George A. Weiss University Professor of Law and Sociology at the University of Pennsylvania, the Raymond Pace and Sadie Tanner Moselle Alexander Professor of Civil Rights, Professor of Africana Studies, and Director of the Penn Program on Race, Science, and Society. Following her, we will hear from our own Dr. Esteban Burchard, who is Professor of Bioengineering and Therapeutic Sciences, a pulmonologist and Professor of Medicine at UCSF. He is the founder and director of the Asthma Collaboratory and the Center for Genes, Environment, and Health. And then our third keynote will be Dr. David Jones. He is the Harvard College Professor, A. Bernard Ackerman Professor of the Culture of Medicine, Faculty of Arts and Sciences and Faculty of Medicine, and Professor of Epidemiology at the Harvard T.H. Chan School of Public Health. And with that, I will turn it over to our first speaker, Professor Roberts.
Thank you, Kirsten. Let me share my screen. Can somebody just give me a verbal okay that everything looks fine?
Looking great, thank you.
Great, thank you so much. So thanks so much, Kirsten, for that introduction and for the invitation to speak in this important session this morning. I've been asked to give a historical and theoretical foundation for our discussion of race and racism in medicine. And I do believe that understanding where current thinking about race in medicine originated can help us work toward being anti-racist in our future work. There we go. To understand how race is used in medicine today, we need to trace current concepts of race and their relationship to racism all the way back to the very origins of the race concept, to the invention of the idea that human beings are naturally divided into distinguishable biological races. The belief in biological races whose bodies work differently originated in the scientific invention of race and the racial invention of modern science. The expansion of the slave trade in the 1700s necessitated an expanding conceptual framework of race, both to justify enslaving human beings and to govern a society based on forced human labor. At the end of the 17th century, many European theologians held that God created the races and made Europeans in his image. With the Enlightenment, the divine was no longer an acceptable basis for scientific evidence, so European scientists pointed to nature instead of God as the force that produced innate distinctions between races. But they basically imported this pre-modern creationism and racial mythology into modern science. Johann Blumenbach, for example, believed that some force of nature, and he borrowed this idea directly from Christian theology, had created 5 races: Caucasian, Malay, Mongolian, Native American, and Ethiopian. And he argued that they all descended from so-called Caucasians. Thomas Jefferson gives an example of this racial idea and how it was useful to excusing racial inequality. Race was invented to justify dispossessing indigenous people in the Americas and enslave African people, and later to exclude them from the new nation, which was supposedly founded on the inalienable rights to liberty and equality. Of course, this posed a problem if you were going to enslave people while you supposedly were creating a new nation founded on the opposite of slavery. So Jefferson's writings show how the false belief in biological race was useful, because he could say that it wasn't because of violence or racism or power, it was because of the real distinctions nature made, why it was okay to enslave people in a nation founded on liberty. Just as the Catholic Church had used biological race as an excuse for enslaving Black people who converted to Christianity. So race is a system of made-up categories for governing people in an unequal society. The reason why Black people are defined as anyone with any African ancestry, regardless of the amount or variety of their non-African ancestors, though of course we all have African ancestors, just depends on what point in time you're going to start counting, which is made up as well. But white people have to be pure to qualify to be white. Well, that's because it was politically useful to white people to construct the categories that way in creating a society where many Black people could be enslaved, but only an exclusive group of white people could dominate them. We still use this political classification system today because it's been enforced since colonial times by legal definitions, court decisions, anti-miscegenation laws, and other Jim Crow laws, and extra-legal terror. In the United States, doctors were essential to legitimizing the slavery system based on natural racial differences rather than on racial violence and subordination. They promoted the racial concept of disease, that people of different races have different diseases and experience common diseases differently. In the 1850s, Southern physician Samuel Cartwright contended that Black people had lower lung capacity than white people and were therefore healthy only when enslaved and forced to work by whites. In his 1851 report on the diseases and peculiarities of the Negro race, Cartwright described a list of diseases that he said were peculiar to Black people, all supposedly supporting his claim that enslavement was good for Black people's health. One of the most striking was his diagnosis of drapetomania, the mental disorder that supposedly explained why some Black people ran away from plantations. Even after slavery ended, Cartwright's ideas that Black people have lower lung capacity stuck, and that's commonly believed today. Doctors adapted the racial concept of disease to argue that Black people bore a greater burden of disease because enslavement had kept at bay their natural propensities toward disease, and that their bodies now could not adapt to freedom. The scientific belief in Black bodily difference also legitimated unethical experimentation on Black people, supposedly to benefit their health. So when the human genome was mapped, with the first draft of it unveiled at a White House ceremony in 2000, and everyone involved said, oh, well, it shows that there is no such thing as race at the genetic level. Bill Clinton emphasized that in genetic terms, human beings are 99.9% the same. It would have been helpful if he also pointed out that the small amount of genetic difference does involve lots of genetic variation, but it can't be grouped by race. So many people thought, okay, now finally, we're going to get rid of this biological concept of race in medicine and biomedical research, and maybe even more broadly in American society. But instead, what happened was just the opposite. We saw a resurgence in interest in looking for race-based genetic differences. And the definitions that originated in a false Christian theology that God created the races and then were taken up in the Enlightenment period to justify slavery, that nature created the races, now was turned into a new genetic or genomic definition that evolution created the races. With definitions like races are population clusters based on genetic differences due to evolutionary pressure. But it's all basically the same idea that nature, some force of nature, whether it's God or just a spirit or nature generally or evolution, created races instead of what we know to be true, that race is an invented political categorization system to govern people and to specifically govern people in an unequal society. So when I began to see this resurgence of interest in looking for genetic differences between races, I wrote a book called Fatal Invention: How Science, Politics, and Big Business Recreate Race in the 21st Century, and pointed out that race was being redefined as a genetic grouping. Again, the same basic definition from the 1600s, but now redefining it in terms of genetics. Then there were genetic explanations for racial inequities, including, and I apologize for some reason my printer is making noises. I'm sorry for that background noise, but that there were genetic explanations for racial inequities, including inequities in health, and that this was seen as a basis for justifying race-specific biological remedies, including remedies supposedly for health inequities. When the American Society of Human Genetics met in 2018, they had to confront the fact that white nationalists were using some geneticists' racial research to support their claims about innate racial differences. The society issued yet another statement, and there have been lots of these statements over the last half century or more, since the end of World War II, really in response to Nazi scientists using biological concepts of race. And we've seen statement after statement about the misuse of biological, in more currently genetic research involving race. But they made it seem as if there's only a problem with using biological concepts of race if you're a white nationalist. There remains lots of confusion within the field of genetics, within biomedical research and medical practice about the use of race. And I and three colleagues, Michael Udell, Sarah Tishkoff, and Bob DeSalle, recently reiterated our appeal to the NIH that they confront the use of race in science and make efforts to end the confusion about when it's appropriate to use race, what race means, what are the implications of using race in biomedical research. There seems to be this persistent misunderstanding or failure to come to grips with the connection between biological concepts of race and racism. A natural division of human beings into races didn't cause racism. Racism necessitated the invention of race, the human, not natural classification of people into socially constructed groupings that we call races. The false biological concept of race and racial concept of disease continue to misdiagnose health inequities. Take, for example, this research hypothesis from a 2007 study that appeared in a leading peer-reviewed journal, the American Journal of Obstetrics and Gynecology, that, quote, Black race, independent of other factors, increases the risk of extreme preterm births and its frequency of recurrence. Black race, independent of other factors, increases risk. First of all, what is Black race? As I pointed out before, the definition in the United States of Black race is not the same, even the same kind of definition we give to white race. There are inconsistent even ways of defining race, which you can only explain in political terms. And that definition varies across time, it varies across nations. It is completely determined by political imperatives at the current moment. And so what do we mean by Black race? How do you identify scientifically people who have Black race and those who don't? How much African ancestry do you need to qualify? The way we generally think about it is any amount. And how can you possibly control for every factor other than this thing called Black race that might affect extreme premature birth? What's more, isn't it more plausible that factors other than some imagined innate Black race contribute to high rates of premature birth in Black communities in the United States? Wouldn't it be far more useful to study and address those factors instead of leaving them out, explicitly leaving them out of a study? These concepts are literally embedded in medical technologies. In routine lab results, the estimate for glomerular filtration rate, for example, an important indicator of kidney function, is listed as 2 different numbers, one for non-African Americans and a higher, healthier one for African Americans. In other words, EGFR automatically and categorically treats Black patients differently than all other human beings. Race-based adjustments like this one are routine in diagnostic algorithms currently used in clinics and clinical research across the United States and approved as standard medical practice. In addition, we know that Black people have been undertreated for pain. So another problem this exemplifies with race-based medicine is that it promotes harmful stereotypes about racial bodily differences, making patients and research participants of color more vulnerable to being mistreated by healthcare professionals and researchers who believe these myths. It's long been documented that clinical staff undertreat Black patients for pain. Studies have shown that Black patients with painful long bone fractures and Black children suffering from appendicitis are far less likely than their white counterparts to get adequate pain treatment. A recent study of medical students and residents at University of Virginia Medical School tied the undertreatment of Black patients' pain to absurd stereotypes about Black people's bodies, that Black people have thicker skin and less sensitive nerve endings than white people. The researchers found that a substantial number of white medical students and residents held these false beliefs about biological differences between Blacks and whites, and that these beliefs predicted racial bias in pain perception and treatment recommendation accuracy. Although the COVID pandemic has impacted everyone in the nation, African Americans have borne the brunt of sickness. They have contracted and died from the virus at far higher rates than white Americans. Why? Dueling hypotheses about the answer go to the heart of our discussion today. Some scientists and politicians speculated that there must be something innately peculiar to Black people that made us more susceptible to illness and death. A better explanation is the conditions created by structural racism that put Black people at greater risk of disease and death. As the former president of the American Public Health Association, Dr. Kamara Jones put it, racism, not race, is a risk factor for dying of COVID-19. And I think that mantra is very helpful in general when we think about race and racism in medicine. It's racism, not race, that is a risk factor. The scientific challenge to biologically deterministic explanations for health inequities goes back at least a century. W.E.B. Du Bois contested the common wisdom in 1899 that newly emancipated Black people had poor health because their bodies were naturally ill-prepared for freedom. In that tradition, there's mounting evidence that racial disparities in health are caused by structural racism. More and more studies at the intersection of the social and biological sciences are documenting the devastating impact of structural racism on Black people's health. I'm going to skip ahead for sake of time. I think we can sum up the mechanisms uncovered by this research as embodying racism, the way racism gets under the skin to produce health inequities. Race isn't a biological category that naturally produces health disparities because of genetic difference. Race is a political category that has staggering biological consequences because of the impact of social inequality on people's health. This isn't a colorblind approach. It recognizes that race is a very real way our society categorizes people, and that this categorization shapes every aspect of our lives, including our health. That's precisely what the invention of race was designed to do. Pretending that race was created by some force of nature obscures reality. A few years ago, I teamed up with Dr. Jonathan Metzl, the director of the Center for Medicine, Health, and Society at Vanderbilt University, to describe how racism has structured medical knowledge and practice and to offer suggestions for ending it. Structural competency, a concept Dr. Metzl developed with Dr. Helena Hansen, who will be a panelist later today, describes an approach to medical training that emphasizes understanding how structural forces affect patients' health. In our article, we analyzed how racism in particular structures medical knowledge and practice, and how healthcare professionals can work toward change. I think insights about structural competency and anti-racism in medicine apply as well to medical practice and research. So in the end, the best way to end health inequities is the best way to improve everyone's health. And that is to work collectively to end structural racism and other inequities and toward a society that values every human being equally. A more equal and just society would be a healthier one. Thank you.
Thank you very much. That was really terrific for setting the stage for us. I want to start with you so nicely laid out why our categories of race are not biologically driven, that racism is in fact what has created those categories. How should we, but we still in the medical literature, the study that you cite is a very familiar formulation of how we would normally do research, even disparities research, to say we've controlled for the other things and now we still find that Black race is related to this. If we say that we don't want to be color blind, but we want to understand disease burden that might be driven by racism, how do we capture racism in those types of studies? Like, how should we be thinking of the sets of patients who have a greater burden of disease that we believe racism is the reason, but how should we capture that and measure that in order to explore it?
Yeah, well, I think the first point in designing studies is to design them, which follows from the hypothesis that you have, right, that you're trying to prove or disprove, and then the methods you use, the theory behind the study that shapes the design has to be that you are looking for the impact of racism on people's health. And so you'll be careful then to if that's relevant. I mean, the first thing I should say is that there may be a study where you're trying to determine the impact of some other aspect of social inequality, or you're trying to determine something apart from the impact of social inequality. You know, there may be lots of research aims that you have, and the first thing is to be concerned about whether race is relevant to what you want to find out, and whether or not it's, and then how you define it. I would say that race becomes relevant if you're looking for how racism affects people's health. So the very first part of it is to be clear in the hypothesis, in the design, in the variables that you're using, that you're not basing it on a false idea of what race is. That's the most important thing. You know, I am not a biomedical researcher, and I think that we need to be innovative in ways that do include sociologists and legal scholars like me, along with biologists, and others in figuring out how to design these studies. But I don't think we've done it well so far. The studies I think that are the best are the ones that have been looking at innovative ways of figuring out how racism gets embodied or gets under the skin, where their purpose is to study racism. And so they're more careful, I think, about the fact that when they use Black, white, Latinx, Native American, et cetera, they're using a socially constructed category. They don't pretend that it's some innate essence or something that's innate in the bodies of the people they're studying that are producing these outcomes. They are designing a study that's explicitly looking at how racism affects these people because of the social category that they're identified with. And so that being clear about the purpose of the study and the meaning of the variables is an important start. Just to take one aspect of what I've been saying, if you take, for example, from that study I pointed to, Black race, there's no definition in the study of what the scientists meant by Black race or the researchers meant by Black race. How are you identifying which participants belong in this group? If you are doing a study that claims that some innate factor puts the participants at risk, then how do you define who has that innate factor? In my opinion, it shouldn't be a social grouping that could include extremely different people. I mean, if you just take the grouping Black, so Black race, who's in the Black race? I mean, it could be somebody who has one Black great grandmother and everybody else is white or Asian or Native. It could be that person. It could also be someone who just immigrated to the United States from Nigeria, all of whose ancestors were from Africa. So how could you put those two people in one study and say that they must have this innate factor you're looking for because we call them Black? That's just the most basic part of it. Is just the variables that you're using and defining them, let alone these deeper questions about how do you design a study and who do you collaborate with to make sure that you're capturing the meaning, the actual meaning of race and the various ways that racism can affect the body. So, and let me just, again, from that study, I kind of pick on that study because the hypothesis was so clear. It was, and so clearly wrong. But also to say, independent of all other factors. Yeah. So are you really going to control for every social factor that could affect premature birth? I mean, I think you and I could sit here and we could think of 100 factors. And the study only controlled for a handful of factors. And it didn't control for the experience of racism. So, does it control for the stress of racism? Does it control for the amount of years that someone lived in poverty? Does it control for environmental toxins in the neighborhood? Does it control for police presence in the neighborhood? Does it, I could go on, right? We could go on and on and on with all the ways that racism structures people's lives in America. And that would have to be taken into account in a study that claims to control for all factors independent of so-called Black race. So those are some ideas about what we need to do and what we shouldn't do. I will just add one more thing, which is that it would be helpful then for researchers who have hypotheses like that to consult with people who are aware of how structural racism affects health, or even just aware of all the ways that structural racism affect our lives. They may not have thought explicitly about what's the impact on health, but they know about residential segregation. They know how that makes people living in certain neighborhoods vulnerable to all sorts of hazards that are bad for your health that people living in other neighborhoods aren't vulnerable to, aren't exposed to. And a biomedical researcher may not know that. It may be more likely that a sociologist would know that. And there has to be a collaboration. And just one more thing, I could go on and on, but one more thing is that in these collaborations, we need equality of respect for the knowledge that people of different disciplines have. I can't tell you how many times people have said to me, well, you're not a doctor. You know, what do you have to say about this? And I always respond, well, clearly I know more about race and racism than you do. So I have a lot to say about this topic. But there is this idea that the only people who know about how racism affects or race affects health outcomes are people who are trained in biology and sometimes specific parts of biology, when that only gives us a partial understanding, especially if we understand that biology isn't just genes. Biology is, has to involve the environment and social factors as well.
Well, I thank you so much for kicking us off with that great keynote, and I'm looking forward to having all of the panelists together to further this exact topic that we're talking about. I'd like to turn it over to Dr. Burchard.
Can you hear me okay?
Yes.
Great. Thank you. It's an honor and a privilege to be here. My name is Dr. Esteban Burchard. I am a physician. I'm trained in pulmonary and critical care medicine, genetic epidemiology, and epidemiology. So here's the big debate that we use in medicine as of today. It's a national debate. And it's whether or not we should use race or ethnicity in clinical and biomedical research. The camp has really been divided into two social constructs. One is race as a social construct. And then two, there are people that advocate that race has a biological aspect. However, we here at UCSF recognize that it's an interaction, in that the social structure of race, which is a social structure, does influence biologic outcomes such as genetics and epigenetics. And this debate has been brought to the forefront, at least at UCSF, and this is an email that was publicly distributed by our chief clinical officer at UCSF, questioning whether or not we as physicians who see patients should use race in our clinical decision-making. Now, this is not unique to UCSF. It is a discussion that has gone nationwide, and many hospitals have elected to categorically throw out race for things such as kidney disease and lung disease. Now, before I go on, I want to tell you a little bit about who I am. I'm Mexican American. I'm born in California. My mother was born in California. This is her father, who's the second from the right, a farm worker in California. And when I took this picture, I didn't realize that it was superimposed on the New England Journal of Medicine, and that'll become relevant shortly. We come from a racially admixed family. These are my great-grandparents, my great-grandfather in the middle, his daughter on his left, my grandfather on the top right. And you could see that we're racially mixed. We're Native American, we're African, as you can see by the hair, we're European. And this is how I looked when I was in college. And I was able to break out of a life of poverty growing up in the Mission District of San Francisco to single mother by becoming a nationally recognized wrestler in college. I was a two-time NCAA academic All-American. This is how I looked when I started medical school. And when Professor Roberts talks about the social determinants of health, I want to remind her that I've experienced these. Now, I look very different now than I did when I was back in college, but the two gentlemen on the left, Esteban and my colleague at the time, Rob Dodds, who's a neurosurgeon at Stanford, on our way to our first medical school exam, were pulled over by the Stanford police in 1990. We were late for our first medical school exam. It reminds me of what happened in 1964, just 6 years earlier, with James Chaney, Andrew Goodwin, and Michael Schwerner. Unfortunately, they were murdered because the police turned them over to the KKK, but you cannot deny that when you're pulled over on the Stanford campus on the way to the medical school exam, that it's going to have a negative impact on you. This is my family before my mother passed away. You can see that she's very dark-skinned and I'm very light-skinned. So that's always left me wondering that Dr. Seuss book, Are You My Mother? Fortunately, I was able to get a sample of her saliva before she passed away, and we went off to 23andMe and got tested. 23 is a private, soon-to-be public company that came to fruition in 2004, along with other direct-to-consumer companies that marketed genetic ancestry testing as well as disease testing to consumers. And you can see my mother's ancestry on the left, mine on the right. You can see that my mother is more than half Native American, substantial amount of African. I have African ancestry. So according to Dorothy Roberts' definition, I am Black. But I've known this for a long time. And rather than put this on the shelf, we've made a career publishing, leveraging genetic ancestry in diverse populations to identify novel genes. We've identified the blonde hair gene in Melanesian populations, and that was published in Science. We've identified the genetics of lung function in Mexicans, again, published in Science. We had our first publication in the New England Journal in 2003. And while I thought that most people didn't care, people like Henry Louis Gates, who are well established in the academic circles, were off to the markets to make a significant amount of money touting the use of race and finding your roots. And everybody seems to be okay with that. Now, at the same time, I was contacted by David Duke. David Duke called me in 2003, right after our New England Journal paper, and said, "Man, you are right on." And for those of you that don't know, by night, he's a Klanman. By day, he's an everyday voter. He's a politician, a member of the Parent-Teacher Association, and a board member. My point in bringing this up is that he's still swimming amongst us. And what I want to bring up is that here is where we need social oversight, ethical oversight of anything we do with respect to genetics and medicine. Now, as I said, I'm a specialist in lung disease, and at an early age, I was interested in asthma, mostly because it's the most common chronic disease of children, but mostly because of this. Asthma is the one disease that has the most significant racial disparities in the world. Asthma prevalence, morbidity, and mortality are highest in Puerto Rican populations and African American populations, and lowest in Mexican populations. Despite that, over 95% of NIH research over the last 25 years has focused in on white populations. So when my colleagues Carlos Bustamante and Francisco de la Vega did a systematic survey of all modern genetic studies in the United States, published up until 2009, we found that 96% were done in populations of European origin. Europeans make up less than 12% of the world population, yet they derive all modern benefits from the Human Genome Project. So essentially, the Human Genome Project was the European Genome Project. Well, that's how we started off. We created a study of recruiting minority children throughout the United States. And like Professor Roberts said, we brought in social epidemiologists that were experts at measuring race and racism, that were expert in measuring social economic status, that were expert in measuring air pollution, and we brought in geneticists who could measure genetic ancestry. We recruited children from all over the United States, including Puerto Rico and Mexico, to capitalize on the variation in diversity of air pollution and socioeconomic status and ancestry. And to date, we recruited over 11,000 minority participants, and we're going strong. We have the largest study of minority children in the United States. And to do this correctly, we collected a variety of measures, including genetic factors, clinical factors, exposure history to diets and behaviors, perceived discrimination, socioeconomic status, and geocoded measures of air pollution. We use this information to differentiate individuals that were healthy from those that had asthma. And then among those that had asthma, we used it to identify the different flavors of asthma, because we know that peripheral blood cell counts differ by race and ethnicity, and it is those peripheral blood cell counts that are used to treat patients. So we are demonstrated that African Americans and Puerto Rican patients do not derive the same benefit from modern asthma therapies called biologics than their white counterparts, simply because of their blood cell count. It has nothing to do with their skin. It has everything to do with the peripheral white blood cell count. Now, Professor Roberts had said we are all from Africa and those dates can be disputed, but that's not true. We can actually pinpoint with carbon dating when people left Africa. People left Africa to go to Europe, to Asia, all around the world. So the contemporary world population is a subset of Africa. Africa has the most diverse genetic diversity in the world. Every other population is a subset. Along the way, the new populations develop their own genetic variants that are private to Native Americans, private to Asians, and those genetic variants lead to differences in drug response and risk of disease. Now, a new event has happened in the last 500 years, and you know this event well. Christopher Columbus came to the New World. He started the slave trade. Native Americans were already here in the New World, so there's a massive collision of three ancestral populations beginning in 1492. And the three populations are African, Native American, and European. And the contemporary population is what we call admixed. And that's what I try to show with these stick figures here with different proportions of colors representing different proportions of genetic ancestry. So like I said, I'm 27% Native American, 6% African, the rest is European. Now this is all well and good, but does it have clinical relevance? I am a physician. I'm a physician scientist, And I only care whether or not our work has meaningful clinical relevance. So Professor Roberts had suggested that lung function was used inappropriately to justify slavery. Now, the spirometer was not developed to reinforce slavery. It was developed to measure lung function, and we use it every day worldwide in medicine to measure lung function. And here's a little picture of little Juanito who has asthma. He has a nose clip. He's breathing into machine. And on the top, we have exhalation. On the bottom, we have inspiration. And the dashed line is before an administration of an asthma bronchodilator, and the solid line is after administration of the drug bronchodilator. Now, we know that lung function is determined by sex. We know it's determined by age. We know it's determined by height. But what do we do in a diverse country like America, in which over 50% of children are minorities? Over 36% of the population are African or Latino. Well, when I arrived at UCSF in 1998, we used a white reference equation for everybody, just like the people who I'm debating here today are arguing for. And instead of having an African-American reference equation, we just took the white equation and racially adjusted it by 15% lower for Blacks, 8% lower for Asians. Now, this is what we call race correction. Fortunately, the Center for Disease Control recognized that there's diversity in the United States. And what they did is they started what was called the NHANES study, National Health Examination and Nutrition Examination Survey, in which they set out mobile vans all over the country. And you can see this diagram on the bottom. There's a reception area, there's a urine collection station, there's a breathing section station, there's a dietary station, blood pressure, everything. And they did this and they standardized it. First, they went out and got all whites. Okay, you could only participate if you were healthy and white. They did all the measurements. They did the same thing for Mexicans. You could only participate if you were healthy and self-identified as Mexican. Then they did this for African Americans, same thing. They measured lung function on everybody, kidney function on everybody. And they came up with normal distributions of what we consider to be healthy. This slide's a little complex, so I'll walk you through it. On the x-axis here, I have age going from 5 to 85. I have males on the left, females on the right. On the y-axis, I have lung function. The higher you are, the better. And what you see is there are 3 different normal prediction standards, one for African, one for Mexicans, and one for Caucasians. And that's because when little Johnny comes into the clinic, you want to make sure that you're comparing apples to apples. So if I tell you Johnny's at the 70th percentile for height, you intuitively know that Johnny is taller than 70% of people, his age, gender, and race, and shorter than 30% of the population. Well, that's what we do in medicine. If you're African-American, we want to compare you to African-Americans. If you're Mexican, you want to compare you to Mexicans. If you're white, we want to compare you to whites. You'll notice that there are no Asian equations. There are no Southeast equations, Southeast Asian equations. So those populations get compared to being white. Now, this is not race correction. Let me be very clear for the record. It is not race correction. It is not race adjustment. It is a race stratified analysis. Now, I had a patient that looked like this gentleman, and gee, I miss him dearly. But I had a firefighter who was African-American, who had an on-the-job injury and came into my clinic. He obviously wanted to get disability benefits. The insurance companies inherently didn't want to pay, so they sent it to me as an independent third-party physician. I knew about 23andMe. I knew growing up that I was racially mixed. I knew that this individual was racially mixed. And here on the right is a graphic display of ancestral proportions of 274 individuals. Green being European ancestry, orange being African ancestry, and every line representing an individual. So President Obama would fit over here, way to the right. So the question that you have to ask yourself, and I had to ask, is even though the clerk that took in his intake information called him African American, when he got to my clinic, since I'm from the hood, I was able to code switch and say, hey man, are you a brother or what? And he goes, yeah, I'm half. And so that really began my journey, my scientific journey. Should we use self-identified race versus genetic ancestry? And so my colleagues and I, we studied 7 independent, healthy cohorts of African-American adults and children and used genetic ancestry. And this slide is complex, so I'll walk you through it. On the x-axis, we have increasing amounts of African ancestry. On the y-axis, we have lung function. The higher you are, the better. And what you can see is that there's an interaction. And what we found is that when we compared our patient to the average reference equation for African Americans versus whites, we got different results. And essentially, depending upon an individual's genetic ancestry, if they were over 70%, 78% African ancestry, we overestimated their disease. If my patient, who was 50% African ancestry, we would underestimate their disease. Now, this again is not race corrected. This is in African Americans only who are healthy, adults and children. So now that we proved this, and we published this in a New England Journal, we published the same results for Mexicans in the journal Science. Pretty good for the son of farm workers. The question that the epidemiologists will ask, or the social epidemiologists, are, do social ecologic factors mediate or confound the relationship between genetic ancestry and lung function? In plain English, are our associations with genetic ancestry just a reflection of being born in a poor environment that has high air pollution, that has high amounts of racial discrimination? Is this the summation of all their life experiences? Since we have the largest study of minority children in the United States with the most comprehensive data, we were able to ask that question. We studied 5,500 Latino children from all over the United States and asked, what is the biggest driver of lung function? Is it genetic ancestry? Is it social environmental exposures like secondhand smoke, air pollution, in utero smoking, number of siblings? Or is it socioeconomic factors, discrimination, acculturation, insurance? And what Maria Pino-Llanes and my postdoc, Nita Tucker, did with the help of Maria, who's a geneticist, they were able to demonstrate that the strongest predictor was genetic ancestry, even after adjusting for the confounders that we knew we could measure. Now, there's no perfect study, and we're never going to be able to adjust for all potential confounders, but this is the most comprehensive study to date on this topic. What Maria went on and demonstrate is amongst 5,500 Latino children with and without asthma, African ancestry is associated with lower lung function. Now, what happens when we have discrepancies? What happens when we have disease misclassification? And in a New England Journal paper, we demonstrated that there's an error rate of as much as 15%. How many of you would like a clinical exam, whether it be a tumor biopsy, that had an error rate of 15%? In the Science paper, we demonstrated that there's an error rate of 10%. Well, when you have disease misclassification, it leads to inappropriate referrals, inappropriate tests, and it has significant clinical implications, including disability ratings, transplant referrals. Remember the comedian Martin He died on a lung transplant list. If he were diagnosed earlier, he might have got on the lung transplant list. It has implications for workers' comp and reimbursement for rehabilitation. Now, here's a warning for us all. This is a paper published last week by UCSF, Dr. Yu-Lin Chuen, and this highlights the danger of the bully pulpit. Untrained popular personalities can have adverse consequences. What Dr. Chuen did is she looked at the number of anti-Asian hashtags from March 16, 2020 to the rise in hate. And what this shows is that people who are untrained but very popular, who venture into fields that they know nothing about, can have dangerous implications and consequences. And that's why we need to be careful. The consequences of throwing out race and ethnicity is like throwing out the baby with the bathwater. If we throw out race and ethnicity, we will default to the dominant population, which as of today, and probably for the next several decades, is going to be European origin. So when someone says, let's throw out race from GFR, they're saying, let's use the white equation for everyone. We need to have a clinical and scientific alternative before we carte blanche throw out race and ethnicity. And again, we have dangerous consequences for not educating ourselves before speaking and publishing. So where do we go from here? As of today, race is used in some medical measurements. It is used for lung disease. It is used for heart disease. It is used for kidney disease. It's used almost every measure that is known to medicine. Where are we going? Genetic ancestry has been around since 2000, 21 years ago. The Human Genome Project started 30 years ago, yet we as physicians and scientists have yet to include it into medical measures such as lung function. To the best of my knowledge, we were the first to do it in 2005. We did it again in 2010. We did it again in 2014, and it's rearing its ugly head in 2021. Where we're going in the future is that we predict that ancestry will become obsolete, in that race will still be a valuable proxy for social determinants of health. But I contend, and we recently published this in a New England Journal on the day of the insurrection, January 6th, that the epidemiologic importance of race and ethnicity will never, ever disappear. It is a valuable construct that captures social determinants of health throughout your life. The takeaways that I would like you to get from this is that race, genetic ancestry, and medicine are tightly intertwined. Race-specific measures are not the same as race-corrected measures. What we could say can have dangerous consequences, and that's a message, a reminder for myself, and a reminder for my colleagues who are speaking today. The epidemiologic importance of race will never go away. Throwing race away without consideration is not an answer. We threw away race for kidney function, and we told people to measure body mass. I can guarantee you that no physician is trained in how to measure body mass. I'm going to end it there, but I want to thank many people from my close-knit team. I want to thank my mentor, Neil Risch. I want to thank the Center for Genes, Environments, and Health, my partners in crime, Elad Ziv, Jennifer Ilarwi, Louisa Burrell, Noah Zeitlin, my whole entire lab, and the Sandler Foundation, who helped me through the darkest days when the NIH wouldn't fund me. I went 0-11 at the NIH, despite having papers in the New England Journal in Science. And then I want to thank all my collaborators. I'm going to end it there, but I'll be happy to take any questions now. Thank you very much for the opportunity to speak.
Thank you so much, Dr. Burchard. So help us to understand, you highlighted the importance of ancestry for and understanding genetic variation for making these types of discoveries. But help us to understand a little bit more about this methodology. If, as you accept that racism and these socially constructed factors determine these racial categories, how do we ever completely disentangle when you map these genetic markers to these ancestral continents, the forces that are actually social and from the ones that are actually genetic? Given that you are starting with self-identified race and then clustering into these ancestral contexts, how do we really know that those are in fact genetic differences as opposed to the cluster of social factors that cluster with racism?
Well, that's actually a very important question. And I have two things to say. First of all, as of today, 2021, there's gross underrepresentation of African, Indigenous, and people of color included in modern genetic studies. You know, things like H3 Africa are making a dent. We need to have more studies like that. There are environmental factors that shape genes, for example, sickle cell. The APOL1 gene that is common in West Africa, relatively absent in East Africa, but because the United States has been largely populated with slaves from West Africa, they have a gene that is a protection from a parasite, and that's why it's been allowed to stay in the population, but it's a significant risk factor for the development of early stage kidney disease. So that's an example where there's a gene environment interaction. Now, what happened in Ferguson and Michael Brown has nothing to do with genetics. That's purely social. If I told you as an insurance agent, you know, what is the likelihood of an individual dying in Ferguson, Missouri? The first cutoff would be, is it male or female? The second cutoff would be, is it black or white? And then it would be your zip code and your GPA. So we insurance actuarials use these proxies all the time for determining your risk. That has nothing to do with biology. With regards to other studies, like the lung function one, as of today, it's an empiric question. We need to do the work. What is more important? Is it genetic? Is it social? Is it environmental? Or is it a compilation of the two? If it is social and environmental, how do we weigh it? How do we weigh me being pulled over on my first day of medical school? How do we weigh that? How do we get internalized? You know, that thing gets, those experiences get in under our skin. And contrary to what Professor Roberts has said, epigenetic factors are inherited. They're passed down from one generation to another generation. So things that happen in my life, it's been proven in Holocaust survivors. Epigenetics is inherited. And the perfect example that we have where we as physicians interfere with epigenetics every day is pregnancy. We give pregnant mothers folate to change their genes to prevent spina bifida. That's an environmental intervention that causes epigenetic changes that are inherited by the child. So it's complex, Kirsten. It is complex, and Professor Roberts had it correct. We do need multidisciplinary teams to help address this.
Great. All right. Well, I want us to leave time for our last speaker and then invite everybody back for the panel following the break. So please let me invite Dr. Jones.
Okay, are my slides up and going?
Yes.
Excellent. Well, thank you for the invitation to participate in this terrific series of events that UCSF has launched. My predecessors have set a high standard. My remarks, as you will see, are more closely aligned with what Dorothy Roberts said. I will try to complement and not duplicate what she has already told us. And I'm certainly grateful that Zoom will spare me from getting pulled into a wrestling match with Esteban, which he would clearly win. While I cannot claim a diverse African, Indigenous, or European ancestry, and while I cannot claim to have been raised in the hood, I can say that I have educated myself before speaking and publishing, and I don't think any of us appreciate the comparison to Donald Trump in this context. As everyone knows, many events over the past year have triggered an unprecedented reckoning with race. Many within medicine acknowledge that we face multifaceted problems, from the structural racism in society that leads to health inequities, to the systemic racism within medicine that leads to disparate treatment of people of color, whether patients, medical students, physicians, or faculty. Many institutions, including Harvard Medical School, where I work, and UCSF and the other UC campuses where you all are, have committed themselves to anti-racism. One challenge here is that we don't know yet exactly what this involves. And one good example of this is the debate about the use of race in medical theory and practice. The fundamental question here is, should we provide different care to people of different races and ethnicities because of their races and ethnicities? Many people say yes, and you just heard a compelling argument for why that should be true. And people who support this see race-based medicine as an evidence-based way to contribute to efforts to solve health inequities. Others, like Professor Roberts, see race-based medicine as the opposite, as neither scientific nor evidence-based, as just another form of bias that can accentuate inequities. Such practices, such as race-based medicine, also perpetuate the pernicious idea that race is a biologically meaningful category, and that then itself has a whole series of follow-on effects in society. Now, critics of the use of race in medicine, Professor Roberts, myself, are often accused of calling for race-blind medicine. I don't know anyone who has done that. I have never seen anyone in print do that. Many of the papers published this winter in New England Journal of Medicine that accused people of calling for race-based medicine significantly had no citations for that claim, because I don't think anyone is arguing that. And also, I don't think anyone wants to use white norms for all people. I have never said that. I don't think Professor Roberts has ever said that. I'm not sure why Esteban suggested that that is what we are calling for. Protagonists on both sides of the debate actually support race-conscious medicine. The challenge here is figuring out what is the best way for medicine to be race-conscious, and what does that mean, and what does race mean? So in the short time I have, I will describe one area of debate, the role of race in diagnostic testing and treatment guidelines. This has come up in both of the previous comments. Since the subsequent sessions in this UCSF series will drill down into the details of these debates, I will focus instead on some of the fundamental questions, the big picture questions at stake in all of this. What is race? What harm is being done? How could we be doing better? So over the past century, I don't think any of you will be surprised to hear this, physicians have operationalized race in many, many different ways. They have produced treatment guidelines that recommend adjusting treatment according to a patient's race or ethnicity. This is an example from cardiology, and you can find examples in most areas of medicine. They have developed diagnostic tests and calculators that return different results based on the patient's race, and you have heard about a few of those from the previous speakers. Over the past several years, a few of these have come to national attention, especially the tests that estimate kidney function, and your colleagues at UCSF have been at the center on both sides of these debates. Now, last June, two of my former students and I, and as had been said in the introduction to this session, much of the work here has really been pushed by students who are surprised by what they hear when they enter into the medical profession. But so two of my former students and I published a review on the question, I would say race correction, but I want to say both race correction and race norming, since Esteban had raised that distinction as a significant one. We described 13 tools drawn from across many medical specialties. While there is indeed evidence defending each of these practices, the evidence is often quite weak in different ways. And implementation of these tools often leaves a lot to be desired. many of these tools require use of a dichotomist variable, black or non-black. And so we argued in our piece, or we expressed our fear in this piece, that these tools, if used as directed, could actually exacerbate health disparities and not alleviate them. Now, our article appeared in the aftermath of George Floyd's death and the Black Lives Matter protests that followed. And it served to amplify the debate that had already begun around this question of the glomerular filtration rate. And race correction and race norming have now become a huge topic of discussion over the past year. Tensions around these questions within medicine were further inflamed by the allegations that appeared last summer that the National Football League uses race-specific norms on its neuropsychological tests to deny settlements to retired Black players who are arguing that they have brain injuries attributable to their careers in football. Now, Esteban said repeatedly that race norming isn't race correction. That is certainly true. What the NFL is doing is what pulmonologists do. They're using different race-specific standards to guide them in the interpretation of these tests, whether pulmonary function tests or neuropsychological tests. I think this is actually a semantic quibble. The outcome is exactly the same. Two people take a test, and the conclusion that is drawn from the test is different because of the person's race. Now, whether it's different because you're comparing it to different standards, or whether it's different because you use some correction factor, the outcome is exactly the same. When we're talking about race norming or we're talking about race correction, it's actually the same issue. Now, this all caught the attention of Congress, in part because of the work of my colleague, Michelle Morse, who was embedded as a health policy fellow in the House Ways and Means Committee for the past year and a half. The House Ways and Means Committee sent a series of letters to many medical societies asking them for an explanation of how they use race in their various clinical tools. AHRQ has now done something similar. In January, the Ways and Means Committee posted the responses they have received, and this is a fascinating and complicated set of readings. I recommend them to any of you who are interested in these questions of race and medicine. It's really an astonishing collection that for many of these societies lifts up the hood, and the automotive meaning of the word hood, it lifts up the hood to show you what these societies are doing, often in much more detail than these societies' publications have ever revealed. And then meanwhile, over the past winter, researchers have continued to publish many new analyses that highlight a whole series of relevant questions, whether the misuse of race in medical school curricula, on a paper that Dorothy and I were both on, or defending the uses of race in healthcare, paper that Esteban and Kirsten were on, and then another paper about embracing genetic diversity, also produced by researchers at UCSF. So the question is, what do we make of all this debate, all of this advocacy, all of this research and writing on different sides of the issue? And so here are what I see as the big picture issues in all of this. First, we all need to be extremely careful in our scholarship. Race, clearly, is both scientifically complex, at the very least, and emotionally highly, highly charged. Many of the authors and readers, as you are seeing in this symposium, have very strong feelings about these issues. Anyone who engages in this debate has a special obligation to be extremely fastidious in their work. Unfortunately, it remains relatively easy to find mistakes by smart and well-intentioned researchers. One article up in the upper left here, published in the New England Journal of Medicine last February, falsely claimed that a combination of hydralazine and isosorbide dinitrate had been, quote, repeatedly shown to be more effective for heart failure outcomes in Black patients. This is a topic Dorothy and I know a lot about. We have been involved in the debates about this drug since 2005. It simply isn't true. Another common claim that will circulate widely amongst cardiologists is that South Asian patients are responsible for 60% of all cases of cardiovascular disease worldwide. That can't possibly be true either. Several groups have claimed that my June article itself was full of errors, misrepresentations, and understandings. Unfortunately, they didn't identify specifically what those errors might have been, so I don't know if I actually did make mistakes or not. In any case, we all need to do our best to make positive contributions to these debates not make errors. As my boss, Evelyn Hammonds, has often reminded me, something about race makes smart people stupid. Second, I'm increasingly frustrated by an asymmetry that exists in medical thinking. Protagonists in the debates have demanded that critics, like myself, like Dorothy, proceed with great caution before ending any practice of race correction. They say that we have to model what effects the changes might have on patients. No one, however, proceeded with great caution when race correction was first introduced. I haven't done detailed research on each of these tools, but as best as I can tell, researchers detected a race signal in their data, offered a tool that addressed that, and won consensus to implement the change. This was often done without a good rationale for the race correction and without modeling how patients would have been affected had the change been implemented. Osagio Basogi, who's now on the faculty at Berkeley, has shown how courts have generally used a standard of strict scrutiny when policies or practices take race into consideration. Such scrutiny is being demanded before race correction is ended, even though it was not used when race correction was implemented. Why would we do this? I think this asymmetry reflects a widespread assumption that race is real and should be acted on. So this raises my third concern, which the previous speakers have both mentioned, the nature of race. Now, this involves two distinct problems. The first is a question of taxonomy. Is it meaningful to divide the human species into subspecies or races? Plato famously demanded that our scientific categories carve nature at the joints. Do race categories do that? As Dorothy had mentioned, for several centuries, scholars in the European tradition have seen race as a legitimate category, a natural kind, either because they reflected distinct acts of divine creation or because the races reflect divergent evolution of geographically distinct populations. In either case, people assume that race correlates with ancestry and that different ancestries are associated with distinct genetic variations. Now, there certainly is evidence for this, as Esteban has suggested. Geneticists have shown links between genetics and geography in many ways. One of my favorite studies, I think it's a cool study, showed that if you very carefully select a population of Europeans, you can show very fine-grained correlations between geography, ancestry, and genetics. Totally cool study. But how often are these race, ethnic, or ancestral categories and their associated genetic variants medically meaningful? This is the fundamental question. Should our baseline assumption in medicine be one of human sameness or human difference? Now, humans, of course, have been grappling with this question for centuries. Even Shakespeare engaged the debate with Shylock's famous and manipulative argument for the similarity between Jewish people and others in terms of anatomy, passions, and vulnerabilities. We need to keep asking this question now. I believe, and this is a statement of belief, I believe that our baseline assumption should be one of sameness, unless there is very good reason to think otherwise. It doesn't mean that I think we should use white data to norm everyone. I think we should collect composite data on all humans and then use that as a common standard for all humans. Now, I am not a nihilist. Yes, of course, there are some medically relevant differences between people of different ancestries. Tay-Sachs disease is more common amongst people with Ashkenazi ancestry. Sickle cell trait is more common amongst people with West African ancestry. But as Jay Kaufman has shown repeatedly, there is danger in applying these differences carelessly. Yes, sickle cell trait is 25 times more prominent in African Americans than in white Americans. But most African Americans don't have it. It would be wrong to treat all African Americans differently because of a trait that exists in a minority of them. And many white Americans do have the trait as well. The estimates are that there are 40,000 African American children born each year with sickle trait, and there are 6,000 non-Hispanic white children who are born each year with sickle cell trait. We have to consider the risk in all people, whatever their complexion. Similarly, while it is possible to find genetic variations that correlate with race, something that provides reassurance to some that race is real, this might reflect in part a sampling bias. So here's a thought experiment. If you divide a population into short and tall people, could you find genetic differences between them? I assume so. Could you carefully design a gene chip coded with those alleles that would separate these people into two groups? I think you could. Well, what about heavier light people? Probably. What about Bostonians and San Franciscans? Maybe. You would certainly see differences in certain gene frequencies on average between people in Boston and San Francisco. Well, is race a more meaningful category than these other modes of difference that you could show have a genetic basis? That depends on how you define meaningful. Should researchers stratify populations by race alone, or should they also have to stratify research populations by height, by weight, by geography? I suspect we could do fine without any of them, but if we're going to use one, then I think we should use all of them. Now, in response to the criticisms that have come up in the past year from social scientists, physicians, I should note I am a physician, so I can play that card too. Physicians increasingly acknowledge race as a social construct, but then proceed to defend the continued use of race on new grounds. Race, they argue, actually is useful as a proxy for racism. Race labels capture something meaningful about the lived experience, about the ways in which exposures to racism are internalized and embodied, altering physiology. This is absolutely a relevant concern. But the question is, can you infer experiences of racism simply from someone's complexion or self-identity? This raises the second part of the what is race problem, how we operationalize race. Here, I think medical practice is deeply, deeply flawed. Many of the tools we reviewed in the New England Journal of Medicine article relied, as I said, on this dichotomous Black, non-Black variable. Some upgraded this and used the US Census categories of 5 races plus or minus Hispanic ancestry. This is neither scientific nor evidence-based. Consider 3 people, each of whom I might meet as a Harvard freshman if they arrive as a Harvard freshman next fall. One might be a self-identified African-American descended from enslaved people, likely with 75% West African ancestry, who was born and raised in Baltimore. Another might have been from an aristocratic family in Ghana. A third might be a second-generation Ethiopian immigrant born and raised in Boston. Do these 3 people have anything meaningful in common, either in terms of their ancestry and genetics, or their lived and internalized experiences of racism? Not necessarily. So why should our healthcare system treat all 3 of them as one type, distinct from all other humans? It just makes no sense to me at all. The same exercise could be done with South Asians. By the early 1970s, researchers had recognized high rates of heart disease in the South Asian diaspora in Singapore, South Africa, or London. Sir Michael Marmot, famous as one of the huge figures in the world of social determinants of health, his first independent research project was a study of this South Asian heart disease, and he was flummoxed. As he explained, the increased risk made no sense. South Asian was not a coherent category, whether in terms of ancestral genetics, dietary exposures, or other cultural practices. And the same exercise could be done with Hispanic. I'm, of course, self-conscious as a white guy from Boston about telling an audience in California anything about the complexity of the Hispanic community. But I think we can all agree that there are people in the US who identify as Hispanic who essentially have no shared continental ancestry, except in the sense that we are all Africans, as Esteban pointed out. Cultural practices also vary enormously across this category, depending on local background, degree of acculturation, and countless other factors. The bottom line is that I've increasingly come to believe that the use of any of the common race and ethnic categories introduces a classic error of empirical research: garbage in, garbage out. Since the categories and their implementation are flawed, I don't see how anything can come from their use. So the fourth thing I want to emphasize is the harm done by these practices. Our ubiquitous reflexive focus on race diverts attention from other factors that are relevant, arguably even more relevant than genetics. Consider pharmacogenomics, one of the first areas of genomic medicine that rose to prominence in the early 2000s. The basic idea is sound. Humans have many drug metabolizing enzymes and drug receptors. These vary between people. Researchers jumped from that to a broader claim that pharmacogenomic variants have a geographic and even racial distribution. As a result, we should prescribe differently to people of different color. As Sally Satel famously wrote in the New York Times, "I am a racially profiling doctor." Well, I believe in medicine. Many of the alleles have small effect sizes. Most drugs are influenced by so many enzymes and receptors that the impact of any one variant might be small. Moreover, the variants are typically found in just a subset of a particular group. Yes, one race or ethnic group might be at higher risk of being slow metabolizers at P452D6, but most members of that group have the wild type allele. It would be wrong to treat all members of a group differently because of a trait held only by a subset of them. Moreover, there are many things other than pharmacogenomic variants that have large effects on treatment outcomes. Cigarette smoking, for instance, upregulates many drug metabolizing enzymes and therefore decreases the efficacy of those drugs. One of my classmates in residency, Jennifer Duren, who's now a professor at Stanford, cared for a woman with schizoaffective disorder. She helped stabilize the patient on clozapine, a valuable but dangerous drug that requires close monitoring of drug levels. During a period of relative wellness, Jen convinced the patient to quit smoking. The patient's drug metabolism slowed down, leading to a rise in her clozapine levels and symptoms of severe drug toxicity. There are many things, likely more important than ancestry, that impact drug effects. Since the 1970s, researchers have documented many other ways in which ways of life affect treatment outcomes. Diet, for instance, can have a huge impact, whether leafy greens, grapefruit, or charcoal meats. When we test drugs, we report outcomes by race and gender. Why not also report them by cigarette use, meat consumption, geography? Any of these can cause statistically significant differences in outcomes. And most dramatic of all, of course, is the impact of non-adherence. Estimates suggest that half of Americans are unable or unwilling to take prescriptions as instructed. You can prescribe according to race or sequence your patient's genomes and practice one mode of precision medicine, but you will likely have a far larger impact on your patient's treatment outcomes by having a serious and respectful conversation about their ability and their willingness to follow treatment recommendations. Now, I certainly recognize that it is easier to criticize practices than to implement solutions. So I feel obligated in closing to make some specific recommendations. As I said earlier, I do not and have never called for race-blind medicine. As long as race and racism continue to structure access to health, wealth, and social resources, we need to study them. We should continue to include race in the descriptive statistics of healthcare, but we need to do a much better job with this. No good can come from dividing the world's people into Black and non-Black. I don't know what a good set of labels would be, but researchers are working to figure that out. Another option might be to drop such labels and rely instead on ancestry informative genetic markers. This remains a work in progress, and I think there's some intractable problems here. But while I support the use of better race categories in descriptive statistics, I am wary of any use of race categories in diagnostic testing or predictive tools. Meanwhile, any effort we invest in studying race, ancestry, and genetics should be matched, probably exceeded, by our attention to socioeconomic status. Too often, studies and authors will say, we controlled for SES, but a race signal persisted. Well, how did the researchers control for SES? Often by relying on a single crude static variable, for instance, a 2- or 3-tier measure of educational attainment, or sometimes income quartiles. That is not adequate. Social epidemiologists have documented many relevant social exposures, and you heard about many of these in the excellent study of asthma that Esteban was describing. We should document as many of those as possible. And moreover, it's not just the current measure that matters. What we really care about is the integral of socioeconomic exposures over a lifetime. Yes, this will be difficult, but humans have accomplished many difficult things. The United States sent 12 men to the moon and brought them back safely. My colleagues at Harvard and MIT developed the country's 2 COVID vaccines in under 1 year. We have an incredibly resourceful and well-resourced scientific establishment. Surely we can solve the problem of descriptive statistics. We simply need to commit to collecting more comprehensive data about patients, both in research and clinical practice. We need to develop clever ways to analyze this data, but we can do this. Our patients deserve better than what we now offer them with race-based medicine. Thank you.
Thank you very much. Thank you very much. So, Dr. Jones, I'd like you to, I'm happy that you got us to potential solutions in the end, but I want to push you a little bit more. One of the things that we do when we, at least at UCSF, that we've done is as patients come in, we ask for their self-identified race and ethnicity. We ask other questions about their identity, and we are trying to be conscious of how we use them in our clinical algorithms. What would be your recommendation to us for how we start? Do we capture more at the outset, maybe the ancestry informative markers, maybe other aspects of SES, maybe questions about racism, or do we do more on the back end to make sure that we don't use it in the diagnostic and predictive algorithms? How should we be thinking, given that we do have an urgency to address the health issues of our patients in the best way possible with the available information now?
Well, I certainly agree that we have the urgency to do the best for our patients. The question is, are we doing that by foregrounding race or ethnicity as the sole or the key variable that we ask about in these things? When you look at medical studies that get published, and almost all of them stratify patients by age, by gender, and by race and ethnicity, and then stop there. That suggests that race and ethnicity are the key variable. I'm not going to deny that they have effects if you define them properly, which I don't think people often do, but there are many other things. In healthcare, like, we never ask patients about income. Somehow it's considered appropriate to ask patients detailed questions, intimate questions about sexual behavior, substance use, illegal activities. But somehow it's too uncomfortable to ask people about income. Well, why is that? Like, what's wrong with medicine that somehow income is considered more intimate than details of your sexual practices? We deprive ourselves of important information about key variables that really do affect the lives of our patients. And so we don't just have this huge void in our knowledge set about how these socioeconomic variables affect things, because we have not studied them as fastidiously as we have studied race, because a priori we thought race was the key variable. And there are other political questions for why income-based measures have been excluded from traditional medical data sets. But this leaves us with really inadequate data. We don't understand the things that really determine patient outcomes, or we choose to ignore the ones that do. As I said, non-compliance has an effect size that's much, much higher than almost any of the genetic effects that have been described so far. I mean, if we want to move towards precision medicine in the future, we need to enable a future that looks beyond genetics to other factors that alter outcomes. I think doing these things would have a series of benefits. They would decenter race from the role it now plays in medicine, decreasing the risk that medicine exacerbates activities. And I agree that this wouldn't be easy to do. We need to rethink how we do research. But I really think our clinical research and our clinical practice needs to be motivated much more powerfully by structural competency, as Dorothy Roberts said, and not about assumptions of race difference as our guiding principle.
Great, excellent. So these have been 3 fantastic keynotes. I want to say that we knew that there would be differences of opinion. I want to, because Professor Roberts started us off, and certainly both of the subsequent speakers, particularly Dr. Burchard, addressed the comments of Dr. Roberts. We're going to begin the panel after the break, allowing Dr. Roberts to respond back so that we can really have a discussion going and address the specific issues that Dr. Burchard raised. Right now, we're going to take a break and come back in about 10 minutes and then have a panel discussion. During these 10 minutes, we'd urge you to reflect on what you've heard here today. What is one thing you would consider doing differently in your work? Many of us are educators, clinicians, or researchers. And what questions are raised by the 3 opening keynote discussions? Come back at 9:55 for our panel discussion. Thank you very much. Excellent. Welcome back. Welcome back. I'm going to invite, I see Dr. Jones. I'm going to invite
All right.
Professor Roberts and Dr. Burchard to join.
It's not allowing me to join videos.
Oh, maybe our,
But
There
now
we
it
go.
is.
perfect, perfect. Okay. Well, thank you all for those terrific keynotes. I saw so many comments in the Q&A, really thanking you for your perspectives and our articulation of the issue. And Professor Roberts, I want to give you the opportunity, since you spoke first and prompted the reactions from the speakers that followed you, specifically Dr. Burchard, to answer back some of his statements of your views, if you don't mind.
Right, sure. So I think that Dr. Jones did an excellent job of responding to some of the disagreements that Dr. Burchard had with my talk. So I thought I would just mention a few specific points where Dr. Burchard explicitly said I was wrong or implied that I didn't know what I was talking about. So the first is that he said I was wrong in a statement I made about African ancestry when I said that all human beings have African ancestry, and what is made up is where we count it as being part of someone, determining someone's race. I never said anything about the migration out of Africa. I know that that has been estimated, to be 20 to 50,000 years ago. But what I was talking about is, at what point do we claim that human beings either don't have African ancestry or we don't need to take it into account? So Dr. Burchard's distinguishing between African Americans and Mexicans and white people is in terms of African ancestry. They all have African ancestry if we go all the way back far enough, to past 50,000 years. So at what point is the point where we no longer have to count it in terms of determining their race? That's the question. And that is a made up time period that I have never found anyone who says exactly at what point after the migration the races were formed enough that we can distinguish them, and we can distinguish African people from other people who do have African ancestry, but we don't have to refer to it. I hope that's clear. That is a completely made up question. It also raises the question, and just to be clear, again, what distinguishes Mexicans and African Americans? If they have African ancestry, right? If we go all the way back, at what distinguishes them to be able to say, well, African Americans have African ancestry and Mexicans don't. Not only that, not to get too personal, but how is Dr. Burchard's mother Mexican and not Black if she does have African ancestry? I could ask Dr. Burchard that as well. Obviously, that answer depends on a political or social definition of who is Mexican, who is Black. And we could say that about every single race. It's a made up definition that there is no scientific or social consensus on. And that is one of the major problems with race-based medicine or race-based clinical practice. Now, that's one point. Another point, I'll try to go faster on the next ones, is the idea that Black people are harmed if we don't take race categorically and automatically into account in either race correction or race norming. As Dr. Jones pointed out, they basically do the same thing. And there is lots of evidence to show, Dr. Jones points this out in the article he referred to, but there's other articles as well that show that Black people will be diagnosed later, not sooner, because of the race norming. They're denied claims, as the NFL concussion settlement shows, or they're denied being placed on a liver transplant waiting list because of race correction. So it's not the case that if we take race out of these algorithms, Black people are going to be diagnosed later or misdiagnosed or denied treatment. There's evidence that it's just the opposite. And as Dr. Jones said, no one is saying to use a white norm as the norm for everybody. What we're saying is figure out a better way of measuring these outcomes than relying on race. And in fact, once we start, like in the EGFR, start saying we're no longer going to use these absolute categorical race distinctions, and it's just, and the distinction between the dichotomy between Black people and all other human beings, then that is when we start to find better ways of measuring these various functions. I also want to make the point, as Dr. Jones did at the beginning when he pointed out, he is a trained physician and he studied this for a long time. As I pointed out, people might say that because I'm not a physician, I don't have anything to say about on these matters, but I disagree with that. But I would point out that the reason why race correction is getting left out of the EGFR in a number of hospitals now is because of the scientific, careful work of nephrologists who have pointed out that this is not good medicine, like Samantha Grubbs and like Amaka Anea at Penn. So
we're gonna have a whole session on that. So I want to give time for all of this.
All right. It's just not true, though, that it's because of lack of training that people are arguing for ending race-based medicine. These are people who are well trained and have conducted excellent studies and know what they're talking about. Okay, I'll just say one last thing because there was one other point where Dr. Burchard said I was wrong. I never said anything about epigenetics. I didn't use that word, so I'm not sure why he said I was wrong about it.
I was thinking of WashU talk in January 2021.
A different talk. Okay, so let me just say that epigenetics, first of all, does not change genes at all. It changes the expression of genes, as I'm sure you know.
But it's inherited.
And there's absolutely no evidence it's inherited across multiple generations.
That's not true.
You're right. Well, you're absolutely right that if environmental factors that a pregnant person is experiencing can cause epigenetic changes in the fetus. But there's no way we could know that epigenetic changes are inherited over multiple generations because we have not studied that.
Yes, we have.
How could we possibly have studied it? Multiple generations haven't occurred since these studies.
No, we've studied it in mice, and it is inherited.
Okay, all right,
So, I mean, this is a topic that I'm familiar with. But let's talk about the first statement about the one drop rule. It's self-identification. I'm 5% African. My mother is about 8% African. But at the time in the 60s and 50s, even though she was dark skinned, she was not considered African. She was not considered white. And so the African-American community didn't embrace her, even though she's darker than you. And the reality is it's self-identification. Yeah. And it's, the Jim Crow law, which was implemented in the 1800s and continued until the late 1930s, said one drop. So if I had been born in the South, I would have been labeled African-American. I would have been able to pass. And so, there's a double standard within the white community and a double standard within the African-American community.
I absolutely agree with that. That's why it's not determined by ancestry. I
didn't say it was.
Well, then
Fantastic. One thing I'd love to bring you to is to help us in our academic health centers here. And I want to pose the same question I asked Dr. Jones. So you know, we have gone through a big effort at UCSF to ask people to self-identify their race, and we have talked about the problems with this. And one of the challenges in this entire set of discussions is when we should absolutely do away with this imperfect measure, or when we should understand its nuance and it is useful for some other things, which perhaps even a marker of racism. How should we think about, should we collect African ancestry or ancestry informative markers for all of our patients? Should we do self-identified race, but just be careful on the back end on how we use it? Should we collect other measures? Dr. Burchard and then Dr. Roberts.
Well, ancestry informative markers is a way outdated technology from 2000. We can now use genome-wide estimates of ancestry, where we use millions and millions of genetic markers, and each allele frequency difference, the cumulative allele frequency difference mathematically can be used to cluster individuals into.
Is it something we should do on all patients when they come in the door?
Yes.
Because it's important for discovery, or because it's important for how we care for our patients?
Well, what we clearly articulated in the New England Journal piece was that we don't know the answer. So I'm a physician, well-trained in epidemiology, and I know when to say I know and when to say I don't know. And so we said that it's an empiric question that needs further research.
Is it dangerous to measure all of these things, either Dr. Roberts or Dr. Jones, as patients are coming in the door? Or what should we measure as patients come in the door?
Well, I think as Dr. Jones said, there's no reason why we should identify people by race as if it either is somehow has some innate information that helps to treat patients, or that it's a proxy for some other important indicator. It would be much better to ask patients about what is important to their health. As Dr. Jones pointed out, whether they smoke, what their income is, what neighborhood they live in. Those are more important than making assumptions about the patient based on their race. So I would say we should think about what are the important factors that determine a patient's health, or might give us doctors some insight in diagnosing illness or prescribing medications and therapies, and use those instead. Race.
Dr. Jones, is it?
Go on, Dr. Jones.
Dr. Jones, is it dangerous to do this? We understand that there's limitations to doing. Is it dangerous to do self-identified race, given that racism is a factor that influences health outcomes and presumably also influences those self-identified racial categories?
As I said, I have no problem collecting data on race and ethnicity in our descriptive statistics of medicine for the reasons you just said. We have to understand how these things are structuring outcomes. I think it is misleading and dangerous to collect that data and not collect all of the others, because that then creates an assumption that the only thing that matters to doctors is a patient's race or ethnicity. In American political discourse, as we've seen over the past 5 years or 5 centuries, many people operate as if they believe that there are fundamental differences between different types of humans. Why do they believe that? They believe that because scientists and physicians have been telling them that for centuries. We have to take responsibility for the impression that we have created in the public at large, that there are fundamental differences between different types of humans, which is something that has a very pernicious effect on political discourse and human lives in this country.
Kirsten, I want to add that Jewish couples for prenatal counseling get genetically tested all the time. And it's because they're Jewish, because they have a higher inbreeding coefficient, and they're likely to have inborn errors, congenital errors, simply because they're quote unquote racial or ethnic identification. So it is something that we use all the time, and it's not a problem.
Dr. Burchard, how would you respond to the concerns that are raised that that the limitations of our other things aside, other measures aside, and even the potential opportunity for discovery, that doing this continues to reinforce and elevate the ideas of biological views of race?
Again, I've reiterated multiple times, it's an empiric question. As of today, we don't have a way to measure the biologic effects of socioeconomic status, cumulative lifetime experiences. I was born and raised in the Mission District, poor neighborhood, single mom. You know, the chance of me getting out was less than 1 in 10,000. I know the effects of poverty. I have scars on my forehead, on my eyes because of being beaten up in the hood. You know, of course, that's going to make me feel a little bit different. And also it's going to get into under my skin and cause epigenetic changes. But we have no way, how do we integrate that experience compared to someone whose parents are professors in academics and they start off life in a different stage of life than I did?
Dr. Jones?
I would say we don't know that because we haven't made a serious effort to try to study that. As I said, we've gotten people to the moon and back. We made 2 novel vaccines in a year. We can do extraordinary things if we set our minds to doing it. We need to set our minds to and it'll be a 50-year project to create lifespan integral data. If we don't start tomorrow, we're not going to have that data in 50 years. It's a hard task. We have to do it. And the comment about genetic testing in the people of Jewish ancestry or in Jewish populations, we have to be careful about the words we use. There's a fascinating pair of legal cases, and Professor Roberts, as the legal scholar here, might be able to bail me out on this, about 2 wrongful birth suits for couples who both went for genetic screening. The couple that was of Ashkenazi ancestry was screened for Tay-Sachs. Sorry, was not screened for Tay-Sachs. Child was born with Tay-Sachs. They sued saying they should have been screened for Tay-Sachs because any genetic counselor should know that Tay-Sachs is a disease with higher prevalence in people of Ashkenazi ancestry. They won that case. The other couple was a French-Canadian case, a French-Canadian couple. The judge decided that a reasonable genetic counselor shouldn't have suspected that Tay-Sachs was prevalent in the French-Canadian population, and therefore was not found to have committed a crime, even though any reasonable genetic counselor in Boston or places that have significant population of French Canadians understand that Tay-Sachs actually is seen in that population. That was the case where the usual race-based practice, testing people differently because they're Ashkenazi versus something else, led to the birth of a child with a terrible disease. We shouldn't do it.
So let me ask, I knew this panel would be too short. Let me ask each of you to quickly say, if we could move, if you could wave your magic wand and help us to think in our medical school what we should be doing and teaching and practicing, what would the ideal world look like in 5 years for you? What would we be doing different, and how would we be doing this? Is it more measurements? Is it less measurements? Is it more? What are we doing differently? Who wants to start? Dr. Burchard.
Sure. If I was an advisor to God, I think the highest determinant of health is socioeconomic determinants. I think socioeconomic position, education, access to clean water are the top priorities in our as physicians and public health advocates. Genetics is way down the list, but also bombing the wrong country and after 9/11 was way down the list.
Excellent. Okay, Dr. Roberts.
Well, I'd say we would understand that continuing to use race as if it were a biological category when it is an invented political system of governing people in an unequal society, that idea would have disappeared. We would understand that race is an invented category, that because of structural racism and other inequities that Dr. Burchard just mentioned, we have a nation that is currently marked by gross health inequities and other kinds of inequalities. And we would be recognizing that continuing to use race as if it were biological impedes progress. It impedes social change. It impedes better medical practice. It impedes better biomedical research. And therefore, we have to abolish using it. It's the only way we will be able to make the changes that we need to make to have a more equal society.
Excellent. Dr. Jones, you have the last word.
So I would hope that 5 years from now, or the baseline assumption of what we teach our medical students and other health professional students is that for the most part, we are members of a common species, that our shared humanity is much more profound than our shared differences. To the extent that differences do emerge, many of them are driven by the kinds of socioeconomic disclosures that Professor Burchard mentioned in his final comments. I think we need to do much more work to characterize those and their effects, and this will be very difficult work, but I hope we are up to the challenge. Again, I'm not a nihilist. I'll certainly admit that there are differences in allele frequencies between people of different ancestral populations. Some of these are going to be medically relevant. I think we need to remain attuned to the existence of those and practice accordingly where they exist. But I suspect that in the long run, if we had proper data sets on socioeconomic status, we would realize that the genetic differences that exist are of relatively modest importance compared to the many, many other factors that affect our patient outcomes. And I hope that the healthcare professionals will direct their attention and their effort towards those most important determinants of health.
Well, with that, I want to thank each of you, Dr. Burchard, Professor Roberts, Dr. Jones. This has really been a terrific conversation, and so many of the comments in the chat and the questions really speaking to their appreciation of each of you and your commitment to this work and this scholarship. So thank you again for starting us off.
Thank you. Thanks, Kirsten.
Okay. Wow, we're going to go right into the responder panel. And this is, we're really fortunate to have Dr. Catherine Lucey, Executive Vice Dean in the UCSF School of Medicine. And I'm going to turn it over to her to launch this responder panel of colleagues from across the UCs.
Thank you, Dr. Bibbins-Domingo, and I want to express my thanks to all of the plenary speakers. It was a fantastic, fantastic session with lots of thought-provoking comments, and I actually thought probably more consensus in some of the areas than might be evident just on first look, and I'd love to hear from our panelists about that. We're going to be joined now with a distinguished group of panelists. I'll introduce them briefly when I ask them to speak at the outset. And I'd encourage all of you to make sure that you look at their very impressive personal biographies online, because all of them have done important work in this area, and that's why they were selected to be here. They also represent all of the University of California schools of medicine, and I think they can help us think through today the practical applications of the controversies and commonalities that we just heard from our plenary speakers. What I'd like actually to start off this panel is to just ask each of our panelists to weigh in on sort of initial reactions or take-home messages, or even sort of lingering questions they have from the panelists. And each of you, I'd like to take no more than one or 2 minutes, because we want to sort of get into some more dialogue with this. I'm going to ask that we start with Dr. Happy Araneta, who is a professor of family medicine at the University of California, San Diego. What struck you most about these presentations, or what questions do you still have lingering that you'd like us to discuss?
Thank you, first of all, for inviting me, for organizing this this panel with the rich discussions. What struck me the most is that they're all correct. All their perspectives are correct and appropriate for different situations. I work on type 2 diabetes in non-overweight Asian Americans. And so just the recognition that we have high prevalence of type 2 diabetes despite the absence of general obesity. We were able to change the screening guidelines to screen Asian Americans at a lower BMI cut point. So otherwise, 1/3 of Asians with type 2 diabetes would have remained undiagnosed. And so the utility of these, is it race correction, in this case, applies to the population that I work with. It applies to COVID as well, where if you look aggregately at Asians, it seems like they don't experience the same rates of infection and mortality. But if you separate Filipinos, specifically Filipino nurses, in California, the case fatality rates is 1.2%, but as high as 26% among Filipinos. So I think my perspective adds to more complexity about dissecting racial categories further, especially in Asians, where we share the same placement in the Asian continent, but there is little shared in phenotype or language or culture among Indians, Chinese, and Indonesians.
Thank you. And thanks for your work in this very important area. Next, I'd actually like Dr. Elisa Fernandez, who is a professor of medicine at UCSF and director of the UCSF Latinx Center of Excellence, to weigh in on her insights from the plenary speakers. Alicia?
Thank you. I think I'd like to make 3 points. One is, particularly for our students, one is that the reason today is so important is that this is the big lie. This is how we physicians, we scientists have been instrumental in justifying the oppression of people, whether it is and in racializing people. Black scholars have pointed out how the Irish and others were racialized in Europe in order to justify their bottom step. So this is the big lie, and we are the chief justifiers of that lie. We are the big priests of racism. Number 2 is how any person who studies immigrant Latinos will say that will agree completely with Dr. Roberts in many ways. In the 2000 census, 42% of Latinos said they were, quote, some other race. It didn't work. Same thing in the 2010 census, over a third. What does this mean? It means that these categories, obviously, as social categories, are obscure rather than elevate some of the things, and that in fact many people have studied among Latinos how they people will place them into racial categories in the United States that the subjects themselves, the participants themselves, do not recognize. And because of that, I use ethnicity, the word ethnicity, and not race in my own work, and have had to change it, as journals have not accepted my use of the word ethnicity, which is a social construct, to refer for African Americans, for others, and that I think that remains really important. The third point is the need to elevate complexity, and in that I completely agree. We had some interesting discussions in preparations for this. Many people say, oh, it's all socioeconomic status. And anyone who studies Latino health knows how that's not true. The Latino paradox is precisely the fact that for Latino immigrants at low socioeconomic status often have one of the highest life expectancies and often better outcomes. So what then can we say to our students? We can say, you can do this. It is okay to hold complex thoughts. It is okay to understand the role of racism, to understand that sometimes this is a useful shortcut in medicine, and most often it is not. It is okay to elevate complexity. And yes, you can do this. I realize that people want easy answers, and that's not where we are.
Thank you, Dr. Fernandez. I'd like to now turn to Dr. Helena Hansen, who is professor and chair of translational social science and health equity at the University of California, Los Angeles. Dr. Hansen.
Thank you. I mean, so many wise things have been said today. And so I think that what I'm about to say will simply reinforce, maybe from another entry point. But I want to contextualize this conversation by thinking about where we are geographically and what that has to do with the medicine that we practice. So rather than beginning with the question that we were provided as panelists or as discussants beforehand of whether race-based clinical guidelines are necessary, I want to examine why the US is uniquely obsessed with race-based clinical guidelines. We sit in the country that spends the most on healthcare per capita of any country in the world and gets the worst health outcomes of any industrialized nation. Other industrialized nations that perform better on health outcomes and spending, such as Canada, Western Europe and Australia, are multiracial, and they have potent racism that, by the way, is often strengthened by colorblind ideologies that won't acknowledge race and racism in the public record. But unlike us, they invest in social medicine, and they do not invest the same energy in debating race-based guidelines. We may not know if investing in genome-wide studies for all patients and practicing medicine based on them will make a difference for outcomes. But we do know that addressing social and structural drivers of health strongly improves patient outcomes. In my decade and a half of research on the use of race in US pharmaceutical development and marketing, I posit that two factors together lead us to the horrifying results that we have in this country. Okay, they're uniquely horrifying results. One, we have the most brazenly for-profit healthcare system among industrialized nations. And two, our for-profit healthcare, pharma, and biotech industries that make up the largest sector of the US economic system depend on a rigid racial hierarchy that structures our national political culture and our biomedicine. So this hierarchy is supported by the genetic determinist ideology that dominates US biomedicine. And it feeds the commercial sale of individually consumable technologies and services to individual patients deemed at genetic risk rather than public investments in health promoting public infrastructures and social systems. Genetic determinism also feeds into a political discourse in which some racialized groups are deemed biologically flawed and less deserving of expensive technologies, particularly if they have less private purchasing power. So I just want to end with 3 points. One, we have to name and push back against the racial capitalism that undergirds our economy. The racial algorithms that we debate are used to decide who gets insurance coverage for and access to different forms of expensive treatment, granted. So this is a problem. But even more pressing is the fact that our country's racist politics prevent us from investing in health promoting social benefits and public resources, from supporting universal healthcare, and from standing up to the expeditious ethnic racial marketing of pharma and biotechnologies that simply take advantage of our hierarchy of white middle-class consumers who can buy the most newly patented technologies, and publicly insured Black and brown people who constitute a secondary market for products that are for chronic conditions that they disproportionately have, largely due to their living conditions, and for products that are about to go off patent from the standpoint of the producers. Two, we need biosocial research. So as Dorothy Roberts and David Jones mentioned, biology responds to social environment. In fact, we are a species that has evolved to adapt to complex social systems. Our biomedical sciences should reflect that fact. Rather than pouring billions of dollars into research that assumes genetic determinism, we must invest in new paradigms like epigenetics, neuroscience, the microbiome research, neuroplasticity and microbiome research that examine how social environments shape human biology. And this will require collaborations between biomedical researchers on one hand and social scientists who have the conceptual frameworks and methods to help invent new approaches that are up to this task, new scientific approaches, biosocial ones. And then lastly, social sciences need to be included as basic sciences of medicine. Rather than lamenting the low level of sophistication about race that we have among biomedical researchers and practitioners, medical schools must invest in robust education in the social science of health inequalities and race, which would provide a conceptual basis for types of practice, such as what I and colleagues call structural competency, that enable clinicians to address community, institutional, and policy level drivers of health inequalities. We must also build a foundation of social science and medicine to incentivize collaborations between biomedical researchers and social scientists through grants and training. Thanks.
Thank you, Dr. Hansen. Dr. Alexander Reykjavik is next. Dr. Reykjavik is professor of pathology and the medical director and chief of the Center for Genetic and Genomic Medicine at UCSF. Dr. Reykjavik, your insights from the plenary speakers today?
Yeah, I think that this was a very educational session for me personally. As a clinical and research scientist, geneticist, actually recent events in our society have sparked really re-examination on diversity, equity, and inclusion, and also has been an eye-opener that has made me think about the use of race in clinical genetics. As we have seen from the esteemed speakers, this is a difficult and complicated topic, and I would say that that's true across UC system as a whole. I personally think that the debate we witnessed is very healthy and necessary. For geneticists, our two former societies, American Society for Human Genetics and American College for Medical Genetics, have stated that race is a social construct. And these conclusions really have come from a lot of large population-based genetic studies that have shown that individual differences are greater than intercontinental differences, and that diversity is really a part of a spectrum and not a matter of discrete clusters. And most of the current genetics literature is now much more sensitive in replacing race and ethnicity with ancestry and populations to capture human diversity. In clinical genetics, we know that lack of diversity can influence interpretation of genetic results by returning results that are unclear significance. We also know that self-reported ethnicity is an imperfect indicator of genetic ancestry. Substantial and disproportionate risk of recessive disease is now detected when carrier screening is based on ethnicity, leading to inequitable reproductive care. Clearly, a pan-population carrier screening that is inclusive of all populations probably would be a better solution. And as part of this series, there will be a discussion about the use of polygenic risk scores and the shortcomings of these scores because of inadequate diversity. So health equity in genetics requires including more diverse populations across all of our studies. And this is really important towards the ultimate goals of personalized medicine, which is to optimize health at the individual level. Therapeutics that are genotype-based are on the rise, and we need to understand the spectrum of genotypes across populations. My recommendations to our students is really to question everything and apply appropriate methods to determine if current race-based measurements are actually needed or not.
Thank you, Dr. Reykjavik. And our final panelist for the initial reaction part of this panel, Dr. Ruth Shim, who is professor of clinical psychiatry and associate dean of diverse and inclusive education at the University of California, Davis. Dr. Shim?
Thank you, Dr. Lucey, and I'm so pleased to be here with all of these experts. I'm going to keep my comments relatively brief because I really want to engage with the attendees that are here today. I think that the reason that we need to reconsider race-based medicine is because of the application. Because our providers and faculty in our schools of medicine, we were all taught to believe that race-based differences are biological. So we were taught to believe in this concept of biological determinism. And that's because most of our physicians do not understand the nuances of race in the ways that we've been discussing them here today. So the UVA study on medical students that came out recently that Professor Roberts discussed related to this belief in biological determinism in the modern era, in the fact that in our medical schools now, students believe that there are biological differences between Black people and white people as it relates to nerve endings and skin thickness and pain. And so it helps us to understand that knowledge in the hands of people who do not have expertise in critical race theory or race or racism can be dangerous. Due to implicit bias and structural racism. And that these beliefs then lead to, because of structural racism, lead to policies and practices that perpetuate and exacerbate health inequities, which Dr. Jones described. So Dr. Leah Davis of Vanderbilt described in a recent op-ed in Scientific American that the field of genetics needs to have a reckoning with its past racist history. And I would argue that genetics needs to do this, but also the entire field of medicine needs to do it as well.
Thank you, Dr. Shim. I think I'm going to actually not use the questions we submitted to the panelists from yesterday. So with apologies for maybe throwing you all a bit of a curveball, but I'm quite confident that you can catch that and engage in really an important conversation. I'm the education dean for the School of Medicine, and what our students have challenged us to do and on a daily basis continue challenge us to get better is unquestioned. But I think it's misguided to lay the responsibility for this work at the feet of students. I think we are in a position where we must change the current practice of medicine to be more scientific, meaning to not consider race as deterministic and biologic. And I think we have to start changing the way that we as faculty, we as practicing physicians, we as leaders of institutions look at race in medicine. Race is unquestionably important in medicine because it's important to patients. It's part of their lived experience, but that doesn't mean that we need to equate that with biologic importance. And I think the conversation today sort of showed us that how imprecise race is in characterizing individuals. And we run the risk of continuing to use statistical discrimination where we try and treat people as we treat populations, and that's not right. So I'd actually like the group to have a conversation about what do we do for the existing practicing physicians who have not actually heard this nuanced conversation today. How do we both educate them and create structures that protect vulnerable patients from misguided decisions based on people who don't have the sophistication around these controversies and challenges in race-conscious medicine. So I'd like to open up just for a general conversation about what do we do today for practicing physicians today so that we become part of the solution and we don't just wait for a generation of students who have been educated appropriately to come into their professional practice.
So maybe I can say my thought is, I think what we can do today is clearly, for example, and this is something that I have been very interested in and engaged is engaged with our societies about why are we using race corrections for certain variables and for certain measurements. And what is the basis behind it? And should we actually be using it or not? And I think that we need to engage with societies that issue guidelines that enshrine this and are followed by students and clinicians. And so I think that this has to occur at the highest level in order to make significant change in the practice of medicine.
So we are sort of suggesting that we do away with race correction or race norming. Is that what you're suggesting, Dr. Rekiewicz?
Well, I'm not going to say that we do away, but we should question, as has been suggested, and review whether this actually, what is the basis for these measurements, and this needs to be at the level of professional guideline committees that issue these guidelines that medical students and physicians follow. Those are changes need to occur at those levels to make an impact.
Dr. Hansen?
So, yeah, I'd like to respond to that. I think that would be very worthwhile, but this comes back to a discussion that we have had amongst ourselves in preparing for today about whether to focus narrowly on race-based guidelines for clinical treatment or whether to broaden the scope. And I insist we must broaden the scope because this kind of intervention won't make sense to practitioners unless they have a foundation in the social study of the creation of racial categories and how our very racial categories that are called into question in race-based guidelines are a part of a larger institution and ideological system. And we've gotten a little bit of a glimpse of how we might move forward with that in the past year because academic medical centers and leading clinical journals, including New England Journal of Medicine, have all of a sudden been using terms like structural racism when they have not been in the past. And this is a direct result of organized political protest and pressure. I just want to say that right up front. Race is a political category, and it's taken political organizing to change the way that academic medical centers are approaching race. And they are amongst the more conservative institutions in our country. And I insist that it's because there is a lot of money at stake. There's a lot of political power at stake in biomedicine. And so I insist that we cannot limit ourselves to a statement about the need to re-examine racial guidelines in diagnosis and care. We have to actually begin CME. You know, you're talking about practicing physicians. Okay, if they haven't gotten it in medical school or in their training otherwise, then CME credits need to be required so that they can benefit from the deep and long social scholarship based on very robust methods and conceptual frameworks about the social origins of race and racism in our medical system and in our country. So I insist that that is a knowledge base that biomedical practitioners must have. So we have to have a conceptual foundation, and we have to have biomedical practitioners appreciating that there is a robust scholarship that until now has been explicitly excluded from medical education and practice. We have to bring that in, and we have to draw on the current moment of political organizing and pressure to make sure that our academic medical centers require, and our certification bodies require practitioners to be equipped not only with what the racial guidelines are for diagnosis and treatment, but what is the conceptual framework. You know, we spent time in medical school understanding the molecular basis for the medications we prescribe and for the organ failure that we diagnose. We spent absolutely no time, I can certify you, in almost every medical center, academic medical center, except for perhaps historically Black medical schools, no time on structural racism, no time on the social scholarship that's incredibly deep and profound around this. So that's what we have to do. We have to have a foundation. We can't just surgically implant this kind of discussion about race-based guidelines. It has to be on the basis of a knowledge base to practice biomedicine that includes the scholarship.
Thank you. Other comments from Dr. Shem, and then Dr. Fernandez, and then Dr. Araneta.
Yeah, I just want to agree with Dr. Hansen and say that, you know, especially when we talk about the politicalization or the political issue that is race and racism, we're really talking about power. We're really talking about power structures and hierarchies. And very few places are as hierarchical and as power divided as the medical institution, the institution of medicine, or even academic medical centers. And so if we're really serious about moving in the right direction on these issues, it requires the people that have the power to be able to make real decisions about about whether or not this is issues that should be debatable, whether biological determinism is a debatable thing, or whether it's it's accepted that this is bad science and bad medicine. And so, you know, at my institution at UC Davis, we're having discussions about mandatory training of all members of the entire health system around issues of anti-racism in medicine, because we feel that that's a value that everybody needs to understand is something that we all have to kind of work on and commit to learning more about. But that doesn't get to, so that gets to our faculty, which I think catches up to where our students already are. But that doesn't get to the person practicing out in the world, who was educated within the system that we've identified as relatively flawed. And so I think that just as Dr. Hansen mentioned, that's where CME comes in. And I think, you know, that's where we have to think about our American Medical Association, all of our organizations, that they have to be, our guild organizations have to be responsible for addressing this. we've seen recently examples of how these organizations have gotten this wrong, including prominent deputy editors of JAMA questioning whether structural racism exists in medicine. So we have a lot of work to do, but I feel confident that we can make a concerted movement in this effort. And I agree, it's the responsibility of those in power to move in this direction.
I think Dr. Fernandez was next. Thanks, Dr. Shim.
I too want to agree with Dr. Shim and Dr. Hansen and bring 2 or 3 words into the conversation, 3 concepts into the conversation, and just to make them more explicit. I'm a practicing physician at San Francisco General. I see patients from all over the world. It's one of the 2 most diverse hospitals in the United States, and I think the way that we have we can go badly off the rails here if we think that this conversation needs to be around the concept of race, as opposed to, primarily, as opposed to additionally the concept of healthcare disparities. We are, as I mentioned, we are the keepers of the big lie and the people who propagate the big lie that not only are there big important biological differences, but that other races and specifically Blacks are inferior, and that's been held and so on. But we are also the keepers of the medical system. And I mentioned that I was a physician because in my 20 years of practice, I have rarely had to contend with the use of GFR or the use of PFTs, and have managed to take care of physicians competently. I look forward to being educated on that subject, and I am neutral on how that should happen and look forward to that education. On the other hand, I contend with healthcare disparities every day. And so my question for us at UCSF, with an incredible leadership in Dr. Lucey, Dr. Bibbins-Domingo, and Dr. Talmadge King, is I am glad that the chief medical officer at UCSF Health wants to know whether or not we should use GFR or PFTs. But I wonder about whether or not it is a real, I know it is not okay. I wonder if we can put that same passion and that same feeling to ourselves when we send out emails about COVID-19 vaccines through mechanisms that systematically disenfranchise our more vulnerable patients, when we do or do not provide language concordant care, when we do or do not provide language access. In other words, there are 2 things we own in medicine. We own the biological degradation of other people and the biological, but the other thing we own is our medical practice. And we systematically disadvantage vulnerable people. And that is where we need to, every time we talk about race in medicine in those first 2 years, we need to talk about healthcare disparities. I'm talking too long, but let me say to the students, look up 2 words. Look up Lysenkoism and try to understand that concept in the context of the discussion about GFR and so on. And then try to elevate the notion of social inclusion and social exclusion. And the reason for that is that social exclusion causes disease, whether that be gay people from all races, or whether that be social exclusion on the basis of class or on the basis of racism or on others. Thank you.
Thank you. Dr. Araneta?
Thank you. What I'd like to see enriched in the curriculum of all of our UC medical centers is inclusivity and representation, where Asian Americans and Pacific Islanders comprise 1 out of 7 Californians, but there is limited content in our curriculum about Asian American and Pacific Islander health disparities. Pacific Islanders have the highest COVID infection rates in the United States, in California, and in 14 states, but that's not included in the national narrative. Filipinos and Asian Indians have the highest prevalence of both type 2 diabetes and gestational diabetes in California, but that's not included. It's often limited to a lunchtime discussion. So training our learners, where a third are Asian Americans, to be aware of health disparities, but most importantly, dissecting the etiology of these disparities is essential in a state with the demographics that we have. Understanding that the reason why Filipinos and Asian Indians have such high rates of diabetes is that they accumulate so much visceral adipose tissue despite having 24-inch waistlines, but would that be recognized in a clinic visit? And what's the reason for that? Is it poverty? Is it the fetal origins of disease? Or is it colonialism as former British and American and Spanish colonies? And what are the implications on trauma and intergenerational trauma with the domestic terrorism that our Asian American students are experiencing now? What are the consequences on outcomes? And it's not just now, it's Chinese Americans being blamed for the bubonic plague in San Francisco over a century ago, and the refusal of access to care in hospitals in San Francisco. So they created the Chinese hospital. So I think that kind of that inclusion, that representation, and then dissecting the etiology, which includes genetic, biological, social, racism, as well as colonialism as cumulative factors.
Thank you. I think what's really interesting about this conversation, again, is the way, to sort of borrow the terms from Alicia early on, the way that all of you are embracing the complexity of these issues, and also bringing it back to populations of people who have historically been marginalized and pathologized. And I think this is one of the challenges when we begin to teach people about healthcare disparities. Some of the current narrative really is truncated at a pathologization of the race or the genetic ancestry. Blacks have more of this. Asian Americans have more of that, without, as Dr. Araneta said, sort of following through and sort of saying, why is that? It is not related to, if it's not related to ancestry or genetics or biologic basis, what is happening here? And I want to push you all a little bit, because I will be the last person to say education is not part of the answer. Education is definitely part of the answer. Required education, I think, Helena, you're right. Continuing medical education requirements exist, and California in particular has been very specific about what unique areas, palliative medicine, substance use disorder, require added attention. I think that's definitely part of the solution. But let's be honest about this. Like with all areas of medicine, some people will have great understanding following education. Some people will not really understand the nuances, and some people won't bother with the education. So I want to push you all again to think in terms of systems and structures about what we could do as leaders of health systems or as leaders of professional organizations to structure a better approach to provide care for diverse populations while we are educating those who are educable, while we get to a tipping point, because we are far from the tipping point of understanding of the complexities of this. I'm just going to put that out there. And if we simply rely on diffusion of information, we will be having this conversation a decade from now, and we might be a little bit better. So what I'm and that's being optimistic, I think. What are the things that we can do? What are the levers that we can pull? Is this a metric issue around quality and safety by vulnerable populations? Let's hear a little bit more about the systems or structures that leverage points that we might exploit to accelerate our work in this area.
Can I hop in here just because
sure.
I totally agree with your pushing us beyond education and classroom learning. And I've devoted the greater part of the last 7 years to working with colleagues to promote this idea of structural competency, which is just one term for a whole host of approaches that other people do under other labels. But the idea is that we have to move beyond knowledge base and recognition and reinvent our forms of medical practice in order to address health inequalities. And so how do we do that? How do we reinvent practice itself based on a thoroughgoing recognition of structural drivers of health as really prominent primary drivers of the health outcomes, the horrific health outcomes that we're seeing. And so there are many different ways. I think that it has to start with local experiments and recognition and supporting of examples of people who have reinvented that practice. And I actually say, I hold up UCSF as a place where a lot of these kinds of experiments and different types of practice involving real collaborations with community organizers and a lot of consultation along the way with the people most affected by health problems about what's important to them, and the use of a whole range of things, including cultural arts and community histories and employing community health workers and people who have the condition of concern as members of clinical care teams. There are lots of these kinds of examples or experiments cropping up across the country. They, without putting undue burden on our trainees, they're actually initiated by trainees many, many times on the medical school side, who reach out to collaborators who are members of affected communities in non-healthcare sectors like housing agencies, criminal justice schools, and also policymakers. And I think the reason why trainees are often very prominent in this is that they have the incoming generation actually has more of a grounding on average in structures as drivers of health than the older generation does. They're simply ahead of us in that. But I'm just saying that it has to be in some ways an elevation of organically developing collaborations that are reinventing clinical practice, systematic theorization about how and why they work, and then propagation of these models of care. They have to be translated, not simply adopted without any attention to local context. Mm-hmm. But this is a long-term proposition. And I'm encouraged that at every academic medical center that I've gone to recently, I'm finding groups of people, they may not be in the majority, but they're a very vocal minority that are saying we're not satisfied with the form of practice that we have. And it's a self-preservative act as well, because we as clinical practitioners are dropping out of clinical practice at record rates. We're burning out. We're reporting that the reasons that we're dropping out are the structural barriers to improving health outcomes among our patients. It's totally dissatisfying to practice in the current system. And so for our own preservation, we have to be engaged in reinventing healthcare. And there are definitely national organizations, professional organizations, APA, AMA, AAMC, ACGME, that can promote this, that can specifically incentivize the practice of a different kind of medicine and a rethinking of medicine. But it's going to have to happen organically with practitioners who see one, do one, teach one, and actively engage with partners outside of medicine.
Thank you. Other thoughts? Dr. Araneta?
I just like to repeat what Dr. Hansen mentioned, and I think we have to depart from opportunities of learning in a classroom setting and have rich lessons to learn from community partners.
I would, can I jump in and ask?
Yeah, please do.
I want to build off of Dr. Hansen and Dr. Araneta. I think that the way that I've conceptualized the social determinants of health and how that relates to structural competence is that underlying the social determinants of health, which are responsible for the health inequities that we see in our society, underlying those are our social norms or our beliefs about populations of people. and our public policies, or the laws, or all of the policies that govern the decisions that we make in society. And so then those policies and those attitudes and beliefs kind of work together to create an unfair and unjust distribution of opportunity in our society, which leads to these differences in health outcomes that we see, which creates the social determinants that create the health inequities that we see. So if we are serious then about trying to change that, education is not really going to get us to where we need to be, because the intervention has to be, so the education helps on hopefully changing some of the social norms, but that's only one tiny little piece. The work has to be about changing the policies, and sometimes the policy can lead to a change in beliefs about populations. So the intervention has to be done at the level of the policies, and that could be institutional policies. So it could be whether you use EGFR or not. That could be an institutional level type of thing, or it could be the way I believe it should be, needs to be more large scale policies in communities. So in local governments and state governments and in federal governments, because all of these policies have an impact on health and health outcomes. So the idea would be then that if we're really serious about making these changes and making these interventions, that we then have to start influencing the policy decisions that get made at the federal, local, and state levels. So as physicians and as providers, we need to form stronger and more serious relationships with our political system. And I'm here in Davis. I'm located in Sacramento, in the capital, and I don't have the reach or the connections that I should, given if I'm wanting to make these changes. So this is work, again, we're not trained on any of this in medical school, but this is work that is critical to advancing the direction that we need to go if we're really serious about changing things.
Yeah, I agree. And I think part of the role of education is to create citizens who advance our democratic, truly democratic values, not the tacit ones that sometimes we adhere to. Alicia?
I completely agree with Dr. Shim and my colleagues, but I want us to focus on getting our own house in order. We own healthcare disparities. We own healthcare disparities. We can change healthcare disparities. We can change healthcare disparities without changing the federal policies and laws, not completely, because the internal logic of how you have to make money and how a health system keeps going is partly driven by that. But there is an enormous amount we can do. I would like my residents and students to have a more complex understanding of race and ethnicity. Yes, but I want people to say it is intolerable that a hospitalized patient will be 5 days in the hospital and no one will talk to them because they don't speak the language. I want people to say it is intolerable that I get 15 minutes for a 20-year-old with a sore throat, and I get 15 minutes for my 70-year-old with diabetes, hypertension, COPD, and CHF. And that I have very few mechanisms by which to impact that outcome. I want to say that we are actors in creating poor health, and that while social determinants affect who gets sick and with what, once people are sick, we are the ones who affect whether they get better or not. And I think in that way, whenever we have a discussion about race and ethnicity and what that means, I want us to say race, ethnicity, and healthcare disparities. Race, ethnicity, and healthcare disparities. And the reason for that is that we own these things. These are ours. We could change a lot of these things in weeks, and yet we don't. Why is that? Is it because we too understand that these people are less than, be it on their basis of their race, on the basis of their national origin? Why is that?
So I just want to, I just want to bring up what actually Esteban said in terms of rating the importance to healthcare, which is the socioeconomic status. And of course, race, which we all agree has very little biological meaning, but is a proxy for structural issues that have affect our health. A busy clinician, it's hard for a busy clinician to grapple with all these issues regarding the socioeconomic status and how the environment in which these individuals live, how it impacts their health. They just don't have the tools to deal with that. And I think that also the care has to be more holistic. We have a lot of determinism. Although some things are in our genes, a lot of things are not in our genes. Actually, most of the stuff is not in our genes. And so we physicians cannot be alone in this. This is a societal issue. And I do think that also what we do as physicians is very much influenced by what is happening in the society. If pandemics and riots did not happen, we may not be having this conversation today. I think that there are a lot of things that have pushed us forward to discuss these issues that are very relevant. And so I think as physicians, we need to find partners, and we need to find big partners, influential partners. And because by ourselves, we will not be able to solve this. Let us not kid ourselves. This goes way beyond hospital and physicians and their practices. So I think that this is an important topic, but individual, we can all, of course, try to make a change, either with our societies, or either criticizing guidelines, or trying to change things which we think are actually racist in our environment. We can just definitely do that. But the bigger changes will require large partnerships for this to happen.
I just to underscore what Dr. Rostkovic and Shim have raised, that we absolutely have to pay attention to the top down as well, and our role in that. And Dr. Fernandez mentioned that as well. We own this. We are health experts. We are often quite absent when it comes to policy with a big P and advocacy, or on the wrong side of the fence. And this is a moment of a window of opening. We are definitely going to be talking about health reform for many, many years to come. But this particular moment in history, we have a window of opportunity, and we can definitely work with collaborators who understand policy advocacy, use our symbolic capital as physicians and other health practitioners to advocate for reimbursements, for a healthcare system that rewards population health outcomes, that rewards the narrowing of inequalities in health, that democratizes the control over healthcare, bringing in people from affected communities, people who are directly affected by health conditions, into decision-making at institutional levels. We got a taste of that with performance-based reimbursement. But we can be at the table and really help to push this from the top down as well as from the bottom up. So I just want to heartily agree with that we need policies and our participation.
Thank you. We're going to go in a minute to some audience questions. There's literally dozens of them, which Christine Dellendorf has been carefully sort of vetting through, and the remainder will influence the work that we do for future seminars like this. What's been fascinating to me is this conversation, I think very appropriately, is looking at the spectrum of responses that we need to take to address the persistent and pervasive problem of both health and healthcare disparities in the United States. And in many ways, we sometimes get trapped into a very small area of controversy. And sort of, it's like the old story about, why are you looking for your wallet under the light, under the lamppost? If you lost it a block away, it's because the light is better here. And so I think that thinking about interventions that we have to take at the policy level, at the institutional policy level, to Dr. Shim's point, but also as individual practitioners, to understand that, fundamentally, a person's race is not their risk. There are many, many factors that we need to help people think about more holistically, and perhaps that's the approach we need to sort of start pushing at the individual clinician level as we're working on policy changes, global education, and redesign of medical education as well. So let's, Dr. Dellendorf, do you have some questions that you want us to focus on? I see Dr. Burchard also has a question. Esteban, did you want to make a comment before we move on?
I firmly believe that being Black is a risk in our society. For police, differential effects, it is disgusting that 400 years later, we're still seeing it.
Yes, I agree with that. What I was referencing was a risk factor for disease. Skin color is not a risk factor for disease.
Ahmaud Arbery is a disease.
Thanks, yeah, agree. Dr. Dellendorf?
Yes, we have a question from the audience. How do you reconcile the problematic definitions we use to define race in clinical trials while also wanting to create diverse study populations and reassure communities that the interventions we study will work in different communities?
I bet my colleagues have a lot to say about this because they have so much experience working with communities that are affected. But the way to reassure communities, in my experience, is not necessarily to say, oh, we're following XY guideline for your community, because there are many of the communities that we're concerned about that have been very poorly served by us. They don't have a good experience with our practice or our guidelines. That's not reassuring. What's reassuring is the way that we engage with them and bring them to the table to discuss what's important to their health and how we should be structuring our healthcare to address that. So, I guess the question, which is, it's a really good and provocative one. For me, it just, it points to a misunderstanding of where trust between healthcare providers and communities comes from. I don't think that, and I'm thinking of the largely Black American and Latinx patients that I work with. It's not a matter of coming to them and saying, but I'm following the latest guidelines from my national professional organization. It really is, what kind of relationship are we establishing, and what values with regard to really following their lead, and what's important to them are we conveying?
I think one of the, maybe a follow-up on that is the comments that we have seen from all the plenary speakers this morning that sort of look at the way we have normed population because of studies that have done predominantly in male European, the descendants of European ancestry that become the norms. I think this question about how do we re-establish norms to broader populations, I think Dr. Rekovic referenced that earlier. Is there a strategy, Alexandra, that you think makes sense to allow us to begin to sort of understand better what clinical trials should be looking at from a diversity perspective?
Well, I think going actually back to Esteban's studies, I think that the binary slots of racial categorizations are totally imperfect and inadequate. I think that using ancestry will give us a much wider spectrum of diversity of the populations. As Esteban was showing, everybody's going to be different by ancestry. We're all individuals. We differ from each other significantly. And I said intra-individual differences are larger than between intercontinental differences. So I think that the race, the very narrow bins may be a proxy for socioeconomic and socio and structural racism experiences, which are also difficult to quantify. But I think our clinical trials have to involve diverse populations from the get-go. And I think NIH has started to actually require for every grant or trial or enrollment that you show that you have diverse populations that are either reflective of the community you live in or reflective of the United States as a whole. But I think we need to drill that deeper because, as everybody has spoken here, the silos of this race or that race, it just doesn't capture the diversity of our populations. And perhaps ancestry is one way of doing it, but maybe others will have some suggestions in what that diversity should be defined as.
Thank you. Dr. Dillon, oh, I'm sorry, Dr. Shim?
Yeah, I just had two thoughts related to the question. And it really gets to this kind of ongoing debate about how do we get communities of color to be more interactive with our research, and how do we build more trust in the research that we're doing, and making sure that there are more diverse populations in research. And I think of it as kind of two important concepts. One is cultural humility. Melanie Turvalon and Jean-Marie Garcia talk about how if you're going to practice cultural humility, one, you have to look at hierarchies that are in place and be committed to dismantling hierarchies between the provider and the patient. And I think that we could look at those same hierarchies in the ways that we've conducted research traditionally, and asked if those models of hierarchies are correct, which I don't believe that they are. I think they need to be dismantled. But then the other tenet of cultural humility is this idea of really partnering with communities, truly partnering with communities, not, I think research has said, oh, you should partner with communities. And so somebody will go and grab someone from the community and put them in a powerless situation where they have absolutely no influence on or informing of the work. So that is not the type of research or partnership that is most effective. So I see the solution as a workforce issue. So innately, again, medicine is hierarchical. It has been exclusive, and the people that have been able to make it in medicine, save for a few people of color, are majority dominant population folks, majority, and in leadership positions, majority men. So I think that the work that needs to be done is to get more physicians of traditionally excluded, of oppressed and minoritized backgrounds into the fields of research, because they don't have these same issues. They don't have these problems. If they're coming into the work to work in their communities and help their communities, there is an innate desire to partner equally. So the work that needs to be done has to be on the workforce level, but it also has to be for the existing providers, the existing researchers. They need to be thinking more from a culturally humble perspective.
Can I add to that?
Address issues of inclusivity and trust, as well as perhaps a more accurate reflection of what is normal in our current populations. Dr. Araneta and then Dr. Burchard, and then we're going to ask just for one closing comment, one from each panelist to wrap up this really fantastic session. So Dr. Araneta and then Dr. Burchard.
There also has to be an acknowledgement about the inherent biases involved in participating in and intentional recruitment in clinical trials. So often I'm a local PI of a 26-site multi-center study where in the final analyses, Native Americans, Native Hawaiians and Pacific Islanders and Asian Americans, their data are dismissed because the sample sizes were too small. And the response in our communities is, well, then why were we enrolled in the first place? And the perception is we are the providers of healthcare, but there's no interest in our disparities. NIH, the Asian American Pacific Islander population is 6% of the national census. However, only 0.17% of NIH dollars are invested in health disparities research among our communities.
Thanks. Dr. Burchard?
I can't show my video, but I want to echo Dr. Shim's point. We need more minority physicians and more minority scientists. Currently, African Americans make up 4% of physician workforce. Latinos make up 4% of the Latino workforce. In California, Latinos make up 50% of the state populace. And just that number has not changed in 40 years. I started medical school 32 years ago, and that number has not changed. And we need to make a big dent in that, because as Dr. Shim had pointed out to, those individuals tend to gravitate, and it's been shown over and over and over, that tend to gravitate to see minority patients and do research in minority communities.
And I think to add to that, Dr. Burchard, is critically important that our faculties become more diverse, that we don't just strive to diversify the entire physician population or a health professional population, but the people who are going to be driving research, educating the next generation, leading healthcare systems through the transformation needed, have to have people who have been in minoritized populations at the table with those decisions. We are almost out of time. Maybe one wrap-up comment from each panelist, and then am I turning it back over to Kirsten?
Yes.
Yes. Who wants to go? Alicia?
To our students, I would say this: elevate intellectual complexity, elevate complexity in all of its forms, and position yourself with a true north. Complexity doesn't mean doesn't mean that there isn't a true north. It's not about our words, it's about our actions. And specifically, place ourselves at the service of our disenfranchised, of our vulnerable patients.
Thank you. Dr. Hansen?
This is probably another way of saying what Dr. Fernandez just said, but you know, the complexity of race and who is left out of a paradigm that necessarily has been anti-Black racism in the discussion, that's been elevated by Dr. Burchard, Dr. Araneta, Dr. Fernandez, and others. We need a scholarly base so that we can really understand those complexities. There is a whole history. There is a whole ideological underpinning and political underpinning to the medicine that we practice. And one thing that's distinctive about physicians of color is that they tend to be curious about that. They tend to, because of their lived experience, reach for that kind of scholarship. It should be a basic foundation for medical training and practice. And so I just want to elevate the complexity, and that we need the scholarship to inform that complexity, because right now we're operating with very simplistic conceptual foundations in biomedicine.
Thank you. Dr. Rakovic?
Yeah, I would like to say that disparity doesn't lie in our genes. Disparities are societal, socioeconomic, and I think that in order for us to make everybody benefit, we need to encourage diverse populations and their participation. And then unfortunately comes with obstacles, because some populations are very worried about scientific research and how it's used. And I think that engaging communities, diversifying our workforce, diversifying scientific workforce, as well as physician workforce, as has been discussed, is actually, I cannot say how important that is to increase that engagement and that participation.
Thank you. Dr. Araneta?
12 months ago, it felt like the world was awakened when COVID disparities amplified the structural inequalities that affected communities of color. But sadly, 12 months later, we're still seeing these inequities in vaccine allocation. Awareness doesn't always translate into equitable outcomes. To the students, I say, remain your strongest advocates, partner with allies from disciplines that you rarely interact with, because that's how we learn, that's how we partner. Create your own advocacy labs, learn from the ethnic studies departments, from the political science, from lawyers, from the community organizers, but don't be complacent.
Thank you. Dr. Shim, the final comment from panelists. Thank you.
I actually just want to elevate Dr. Jones's words that he said before, that this is hard work. This is a big task that we are setting out upon, but we have done hard things before. And so I've said this before, that I remain skeptically optimistic about our ability to make change and move forward in this area.
I know from the many questions and comments on the Q&A how very valuable our audience has felt this conversation has been. And people are here from all levels of the medical profession and other professions as well. So I think that the work you've done today and the presentations you've made and the discussions you've led really are going to move us forward in a very deliberate way and prepare us for the next set of seminars in this series. So with that, I'm going to turn it back to Dr. Bibbins-Domingo, who was the brainchild and the innovator around this series, and let her have the final comments for today.
Great. That was a really phenomenal panel discussion. I appreciated the morning, and then also appreciated my colleagues here from across the UCs broadening us to the discussion. I think that we have, there are many questions, and seeing our audience so engaged this entire time, I think speaks to the importance of this topic. I loved the call from Dr. Jones, and then from the rest of you, to embrace the nuance that we're up to the challenge, that we can actually do the hard work that actually needs to be done if we're going to both train the next generation, do the best in our care for our patients, and to conduct research that will ultimately provide knowledge for everyone. I want us to, as we close out and look forward to the next sessions, to think about how we take the broad concepts that we've had today and really think about the decisions that we are all faced with on a day-to-day basis. To think about the decision that we made to take the race out of the EGFR, and then the subsequent conversations we had to have also about, is it reasonable for us to put more COVID testing available to Latino patients because we know that there's a disparity there? What does that mean to have those conversations? How can we be fluent as a community in understanding what one decision is and the implications for other decisions? What does it mean when we say race is a social construct, but we want to diversify our clinical trials? Why do we want to diversify our clinical trials? What does that mean for us to say that that is a goal that we as an institution have to do? What's the basis behind that? And I think that these aren't questions that have easy or right or wrong answers, but they are the ones that I think we struggle with every day to communicate with our colleagues amongst ourselves. And as Dr. Lucey said, to communicate not just with those of us who've thought a lot about these issues, but with all of us as we try to create a community of scholars and practitioners. So we have many more sessions to continue to have these discussions. My hope is that you will continue to have these discussions in your own groups and on your own, and give us feedback on our session today, and as well as the sessions going forward. So the next two sessions are really asking us to grapple with the specifics that go behind the decisions that we make every day in medicine. Our case studies on April 7th will look at race, racial categorization, and racism in medicine today, starting with a clinical vignette and then several really outstanding speakers. We are going to continue with case studies on the 14th, including on EGFR and on polygenic risk scores and ancestry. And so I would urge you to join those discussions on our session 4 at another Wednesday, still to be determined. We're going to drill down deeper into the specific mission areas that are important to all of our campuses. Give us feedback on today's sessions, join these other sessions, and help us to continue to figure out how to extend what I think is a very important conversation. Thank you very much.